and we shall start with the first session. And it's a very interesting topic, not much talked about, but nevertheless extremely important for chronic diseases, and that is about diabetes distress. And for this, we have the recognition and therapy of it. And for this, we have Dr. Ashish Dengra from Jabalpur. I request Ashish Dengra to please come to the stage. And I also ask Dr. Natarajan, our chairperson, to please come onto the stage and conduct the proceedings. Dr. Natarajan, please. He is from the Symbiosis University.
Okay, for me to say something? Yeah, we can start. Yeah. Yes. Okay, so good morning, everyone. Those physically here and those virtually present as well. Welcome to this IDEC, and it's my proud privilege to welcome you to the Symbiosis University Hospital and Research Center, which IDEC has very kindly on your screens. You can see his illustrious career as well as his achievements. So I now invite Dr. Ashish Dengra to deliver his talk.
Hello. Hello. आ रहा है ऑडिबल? हेलो, चालू है? बंद रहेगा ना? इसमें बोलना है. Hello, hello. So in the coming few minutes of journey, we will be going through the burden of diabetes distress in type 1 and type 2 diabetic patients, and what is the difference between major depressive disorder and the diabetes distress. Comprehensive approach will be done for screening and diagnosis of diabetes distress, and how the treatment approach should be there, we will see in the coming few minutes. What is euthymia? First we should know, then we can understand the distress. Eu means normal, well. So euthymia means well mental health, good mental health. So that is required in diabetic population also, because our patients are afraid of the disease. They are diagnosed, they are in the mode of depression, denial, or any various modes are there when the patient is diagnosed with diabetes. So to begin with, we will start with the burden of diabetes distress, and what is the understanding and the hurdles living with the patients who are living with diabetes. Diabetes is a disease which has a profound impact on both the physical and mental well-being of the affected individual. You know that diabetes-related stress or distress, that is diabetes distress DD, which I call, it leads to burden of self-care, interpersonal issues, emotional worries regarding the ability to cope with the illness. There are relationship with the caregivers and healthcare professionals which are very important part which we neglect. So diabetes distress is defined as opposite of euthymia. That is defined as an emotional response characterized by extreme apprehension, discomfort or dejection due to perceived inability of the patient to cope the challenges to live with diabetes. So it is the extreme apprehension, discomfort or dejection to live with the diabetes. So my dear friends, we know that prevalence of diabetes distress is very high, which we neglect in both type 2 and type 1 diabetic patients. It is about 36% in this study, the overall prevalence of DD was found, that is diabetes distress. And in type 1 diabetic population, the prevalence was 42.1% and 54.4% was incidence in type 1 diabetic population. The time points in diabetes patients' life, they are associated with increased level of diabetes distress in these stages. At the time of diagnosis, at the time of learning how to self-manage the diabetes, at the emergence of a complication, at the time of switching to the insulin or oral therapy, and even they are distressed at the time of switching over the doctors or healthcare givers. So diabetes distress is often confused with depression in our day-to-day clinic. So how you can differentiate the diabetes distress with the major depressive disorder? So major depressive disorder we know is a complex and disabling condition which frequently coexists with diabetes. In many patients we see they are depressed, but diabetes distress is different than the major depressive disorder. In type 1 it is nearly about 12% and in type 2 it is 19%. So patients with diabetes and major depressive disorder have ultimate poor health outcomes and they have high mortality. So is diabetes depress labeled as same as clinical depression? No, my dear friends, it is not the same. And unlike depression, the diabetes distress is a persistent over time associated with glycemic control and disease management problems, and it is expressed in terms of magnitudes, that is severity, and content, that is nature of distress. So diabetes distress and depression can co-occur. However, it is important to differentiate them and treat them accordingly. So major differences between the MDD and DDR, the major depressive disorder should have at least 5 of the 9 well-defined symptoms that we will see, and that persist for at least 2 weeks, like not having the thrill in watching the TV, playing games, he is depressed, not eating properly or overeating. All these are some symptoms of depressive disorder. So based on patient symptoms considered as a comorbid psychiatric disorder, in contrast, sorry, the DD, that is diabetes distress, is defined by context of diabetes and its management and includes a wide range of emotional experiences. It is based on source of diabetes distress. It is not considered as a separate condition indicating psychopathology of the different forms of the spectrum of diabetes. So the depression, I have told you 5 out of more of the below mentioned symptoms should be present. That is depressed mood, diminished interest in the activities, change in appetite, change in sleep pattern, either he is sleeping more or less, psychomotor agitation or retardation, fatigue. All these are the symptoms of depression. In spite of that, the diabetes distress, the patient is unmotivated, burnt out, overwhelmed, frustrated, angry, he is feeling guilt, fear of hypoglycemia or complication, and he feels lonely. So these are the basic differentiating features between DD and MDD. So there are various diagnostic criteria for DD, that is problem areas in diabetes, PAID, diabetes distress scale, that is DDS, and for depression we know that there is PHQ-9, Center for Epidemiological Studies depression scale, which is CSD. So measurement of depression and distress is important owing to high prevalence of comorbid disorders and persistence of depressive affect and diabetes distress over time. So you have to follow these scales or screening pattern. You can teach or make a multidisciplinary team in your clinic to diagnose this diabetes distress, to screen it, to counsel the patient. So screening and diagnosis is very important, but because you don't have time, you have to make a team in your clinic. So need for development of diabetes distress scale, there are various limitations in the measurement used for screening diabetes distress. There was 2-point scale, which was used previously, which included feeling overwhelmed or feeling that I am often falling with my diabetes routine. It is not proper. Now the newer scale is 17 features scale. It is very cumbersome to do it in our clinics, but you can train staff that just ask these questions, and if it is not a problem, you give the score of 1. If it is a problem, it is a very serious problem, then it is 6. So out of these 17 parameters, you can ask the patient one by one, and patients are required to consider the degree or level to which each of the items included in the scale may have distressed him or her during the past 1 month, and then to circle the appropriate number. So basically, this is a multidisciplinary approach therapy, or for even diagnosis and treatment also. So 17 DDS score aids in identifying major sources of diabetes distress, that is powerlessness, negative social perceptions, friend or family distress, physician distress, hypoglycemia distress, management distress, and eating distress. So these are the various features which we should rule out, and these are the areas where we should screen the patient. The 3D study have highlighted that DDS-17 score have shown the key diabetes variables, that is the HbA1c, self-efficacy, healthy diet, and physical activity. So if the patient is having diabetes distress, A1C will go high, he will have less diet control, and physical activity will be less, and self-efficacy, self-management will be less. So if the diabetes distress is overtaking your life, so you will have bad control of diabetes, diet and exercise will be left behind. So coping skills assessment are usually primary investigation for DD prevention and treatment. There are 6 styles analyzed by glucocopper questionnaire: the negativity, acceptance, blame, optimization, planning, and action. All these you have to screen in your patients, that how the coping styles are there, and the management strategies are very important to improve the self-perception, to improve the coping skills, minimize the burden that needs to be coped with, involve other partners in coping. So my dear friends, in this, the family support is very important to overcome the diabetes distress. So it is a self-perceived insufficiency of coping skills, hence most management approaches need to be focused on the individual. So diabetes distress is very important to diagnose and to treat it. The self-care is very important to train the patient for self-care, for the healthy dietary habits, exercise habits, self-monitoring of glucose, and if he is on injectable therapy or oral therapy, they have to be taken care of their own. So self-care is very important. There is a AEIOU approach for the therapy, and that is ask and assess coping skills A, eliminate negative coping skills E, internalize positive coping mechanisms, observe ongoing basis, upgrade one's understanding. So AEIOU mechanism can be taken for therapy, and for minimizing discomfort of change, you require the breaking changes suggested to discrete bits, prioritizing action for change, focusing on essential parts, making complete use of human resource and technology. So methods to minimize discomfort of dealing with change caused by diabetes are simple. You have to train them in these areas. So targeted areas are diabetes-related emotional burden, physical stress, regime-related stress, or interpersonal distress. So multidisciplinary treatment approach, which I have told you, is specifically targeting the 4 areas of distress. They are very crucial for diabetes-related distress management. So multidisciplinary approach, which will take care of emotional burden, interpersonal distress, regime-related distress, and physician or healthcare-related distress. So these treatment approach team, you have to make it. So my dear friends, the clinical pulse, the alarm is belling. You have to diagnose these patients at early stage to prevent sudden fluctuation in A1C levels, to prevent the major life changes and emotional reaction of negative results. So, sorry, you have to diagnose this DD very early in the stage of diabetes patients, which we are missing. So to teach them how to cope with the distress, So listen to the patient properly, identify the underlying feelings can help manage distress properly, help patient to talk about the experience of having diabetes, identify the specific source of their distress, normalize these feelings, and help patient to cope with distress as a part of regular diabetes care. To summarize, the key take-home messages are: diabetes distress refers to the emotional response encompassing the extreme apprehension and discomfort consequent to the perceived inability to cope with the challenges of living with diabetes. So our newly diagnosed patients are very much afraid that how I will live my life with the diabetes. So we have to teach them that you have to just follow the diet, exercise, and take the medicines properly so you can live the normal life. So diabetes distress has to be overcome by counseling and proper channelizing the patient to the various aspects of psychological therapy. Differentiation of diabetes distress from depression is very important because the treatment approaches are different, and identification of cause of distress and optimization of practical aspects of diabetes distress management contribute for overall health and well-being of the affected individual. So to finish with, my dear friends, we know that this is a very neglected part, that is diabetes distress, which we don't diagnose. So we need a multidisciplinary team in our clinics, as we have trained the diabetic foot, our paramedical staff for foot diagnosis. The problems of foot are to be screened. So we have to make a multidisciplinary approach in our clinics from today. If the patient is coming, you should say, or you can train the dietitians or your paramedical staff that you should inquire about those 17 questions and to diagnose the diabetes distress. And by psychotherapy or counseling, we can overcome the phobia that the patient is diagnosed with diabetes. So thanks a lot for your patient hearing.
Thank you, Dr. Dhingra. That was a very enlightening talk for me personally, because I had never even heard of this concept of diabetes distress. Just to set the ball rolling in terms of questions, I mean, you had vast experience in this field. And as we know, as a society, the incidence of major depression is increasing. And we see that especially even in our campus, amongst the student population. So I just want to know, in your experience, how much is the overlap between people having depression and having diabetes, and how do you deal with a situation where it's a combination of the two, as to know how do you go about the approach? Because I understand the diabetes distress, you say, can be fixed with counseling, obviously, but with glycemic control as well. Whereas major depression obviously goes to a psychiatrist. So how do you deal with this combo kind of situation?
Yeah, very nice question, sir. Basically, 30 to 40% prevalence is seen in type 2 diabetic patients with some degree of depression. So we have to again counsel from our clinic also from the beginning, and we have to start the management from our clinic in spite of sending them to the psychiatrist in the first visit or second visit. So you should try to minimize his agonies or symptoms or problems. You have to sit with them. You have to talk with them that what are the problem areas which he is facing when he was diagnosed with diabetes, and whether he has trained or has accepted the diabetes in his life. Because when the diabetes is diagnosed, the patients are in the few modes. Some patients are in denial कि मुझे तो sugar हो ही नहीं सकता, मेरे मम्मी पापा को नहीं है. Some go into depressive stage. Some are agitated कि मैं ही क्यों. So we have to diagnose the various areas where the patient is in. And if the patient is in major depressive disorder, you have to immediately refer to the psychiatrist. So first stage, we have to counsel in our clinics, and then we can send if the patient is having very severe symptoms.
Thank you, sir.
Thank you.
Any other questions?
Thanks a lot for your patient hearing. Thank you.
Fine. Thank you very much, Dr. Dhingra. So next, we move on to guidelines-directed management. The initiation and continuation in patients of heart failure with reduced ejection fraction, the key to success. Dr. Jagdish Hiremat needs no introduction to this audience, not just here, but
Thank you, Dr. Vijay. Thanks the organizers. I think it's a bit disheartening to see only so many in the audience. I don't know how to complete this 30 minutes talk.
Sir, you're being watched online. It's being telecast online.
Okay.
So they're online attendees.
Okay. So we are going to discuss guideline-directed medical therapy, initiation and continuation. Everyone knows now the guidelines have become very crystallized in this management. So there is a little gray area related to the initiation and the continuation. So we'll see some aspects of those. Actually, we've gone through a lot in the last 2-3 years, and this is the stage, even I reached this stage of mujhe webinar nahi chahiye. And it's glad that at least some hybrid thing is happening, but we are still not out of this masking business, and we shall continue to do so for some more time. In heart failure management, in the late 90s, we realized that high sympathetic tone was a problem, and a drug which was totally contraindicated, beta blocker, became the drug of choice because sympathetic system was creating a havoc in heart failure people. The other system which was heightened was the RAS system, and if you could block that with the ACE inhibitor, and the olden trials are all related to ACE inhibitors, that brought in some benefit. Till about 10 years ago, it wasn't realized that this nitrolytic peptide system gets enhanced or it gets suppressed in heart failure, and if you enhance it by some means or the other, probably you would get benefit in the heart failure treatment. So they tried with neprilysin inhibitors, but it did not work. So finally, they combined with a sacubitril, which is a neprilysin inhibitor, with a valsartan, the ARB, because the combination with ACE inhibitor was causing too much angioneurotic edema. So this combination finally worked, and it's now known as the ERNI. And ERNI has revolutionized the management of heart failure. Paradigm was a trial which brought in paradigm shift in the way we managed heart failure with reduced ejection fraction. And ERNI found a big foundation pillar in the management. Nowadays, in fact, what was a very disheartening disease to treat in the past has become a very rewarding disease, because we see patients who had ejection fraction of 30% now coming back with normal ejection fractions. We have patients who have gotten off the transplant list because their EFs have improved. And if you put the foundational therapy correctly, and if the patient has a disease like a cardiomyopathy, hypertensive heart disease, where there is no scar, the heart is not dead, they improve remarkably, like a puerperal cardiomyopathy. They can do very well with this kind of a treatment. And it is one of the rewarding diseases that we are treating nowadays. So the foundational therapy was ACE, ARB, and ERNI was one base. The MRA, that is spironolactone, and eplerenone group, that is a second base, because this is the only diuretic which brings in disease modification. It prevents the ventricular remodeling. Loop diuretics will give you symptom relief, but MRAs will give you long-term related to myocardial fibrosis. Beta blocker had anyway revolutionized in the past. The best mortality benefit in heart failure comes through beta blocker. So that would be always the first drug to start with, despite its limitation. And the new dapagliflozin heralded onto the scene with the DAPA-HF trial it was a momentous victory in the war against heart failure. And if you put these 4 foundational treatments into management, you can do wonders to the patient. In fact, it almost works like a symphony, wherein all violins put together rather than a singular one make the things work very well. So if you give 1 year outpatient mortality and combinations of foundational medical therapy for heart failure, the red bar here is no treatment, only ACE inhibitor, beta blockers, ACE ARBs and something else, only ARBs, and the foundational therapy. That brings in your best mortality benefit. So combination therapies, all 4 of them combined, then titrate them within a span of 3 to 4 weeks. You should have all the 4 drugs at the best possible doses. Initiate first and then titrate is what we are looking at nowadays. And now going beyond the guideline-directed therapy, the 2 drugs which are on the horizon. One is the Vericiguat, which will be available in this week for management. This is for people who have worsening heart failure. Somebody had a admission or now going home after acute decompensated heart failure. That is where Vericiguat comes into picture. And we always struggle with people with hypotension. That you can't start ARNI, you can't start beta blocker, you can't start too many diuretics. Then that is a drug which is omecaptive mecarbil, which is like a, let's say, modern day digitalis. It's also on the scene, but today the talk is on GDMT, so I'll restrict myself to the first foundational therapies. So if you have a Ffref, that is reduced EF, you start with a ACE-ARB and a beta blocker, definitely. You can add a ivabradine to a great extent, a great advantage, because many a time beta blockers drop the blood pressure and the heart rate advantage is not achieved. So you are on a carvedilol 3.125 twice a day, but the heart rate is sitting on 84 and the blood pressure on 100. So you can't increase the carvedilol. So then you add a ivabradine, suddenly the heart rate becomes 60, 65, and there is a remarkable benefit related to that. So with or without beta blockers should be ivabradine. Then your MRAs, definitely. And then on the side, you have a rehabilitation, comorbid management like diabetes, fluid management, electrolyte management, and IV iron. I think this is one of the changing, really changed major therapy in heart failure. Whether the patient is anemic or not, nowadays one has to send what is called as a iron profile rather than a lipid profile. Other than the lipid profile, you send an iron profile. And if you find that the ferritin levels are low, intravenous iron can bring about remarkable changes in them. So just once in 3 months, once in 6 months of IV iron makes a lot of difference. Oral iron doesn't work in this situation. So you have to give these specialized IV iron, which is, shall we say, has very little side effects and can be instituted very well in a smaller nursing homes as well. And other drugs will be isosorbate dinitrates. So when all this fails, then you go on to the ICDs, the CRTPs, the ECMOs, the left ventricular assist devices, and the transplant. But the GDMT is in the foundational 4, and as I said, dapagliflozin is added to it. So the GDMT is a forefront in the management of heart failure patient. You can check only the yellow box. The key goals of GDMT is uptitration to target doses, introduction of newer therapies, and evidence-based approach to comorbidities. The ACC 2021 consensus recommendation is that GDMT is a foundation of heart failure care, and GDMT with the highest expected benefit should be prioritized, which all of us understand very well. The gray zone related to this was a patient who was getting discharged from the hospital. He has a hypotension, not many drugs are well tolerated, too many symptoms, but there are a lot of trials which were initiated right inside the hospital with a blood pressure of less than 85, less than 100, less 80, 90, all these were initiated. And now we are at a good post-discharge strategy wherein we know that if you have most of the drugs on board at the end of 1 week, if you initiate them inside the hospital, at the end of one month, they're more likely to be continuing, more likely to tolerate the medicine. There will be prescription which is honored, they're likely to adhere to the prescription and persist with it and feel better. All this can happen if you start the foundational pillars inside the hospital. And the best part is of the SGLT2, whether it can be started with the same dose, no titration required, 10 milligrams started and continued for heart failure management, whether other doses would require a lot of adjustment to be done. So they are thinking, or we have been already instructed to change the sequence of events. For example, as I said, one would invariably start a beta blocker with or without ivabradine. And the second need not be ARNI. Second could be an SGLT2 inhibitor because it doesn't drop blood pressure. So the sequence doesn't have to be monotherapy, add, but start with a sequence of not hemodynamically disturbing drugs. And finally, at the end of 4 weeks, you should have up-titrated all the 4 foundational pillars. So the recent ACC 2021 consensus recommends initiation of GDMT as early as possible and to manage these heart failure patients in this manner. See, if you don't give the GDMT, that is lack of GDMT, it can have clinical outcomes which are very startling. You can see the curves. The yellow one is where the GDMT was offered, and the blue curve indicates too much events because the GDMT was not offered. The lack clearly shows higher risk of mortality, and this is the Indian patient studies from Kerala. Lack of GDMT was associated with increased risk of mortality in these patients. You can see the 2 curves clearly separating out. Lack of GDMT was associated with higher risk of hospitalization and emergency visits. Why everyone is harping on this heart failure hospitalization is because now a new drug which comes in cannot show great mortality benefit, because already the established therapy is so good that for a new drug in a short span, and legally you cannot do a trial without the existing GDMT. To show the benefit beyond that, the new drug has to do something else, and that is heart failure hospitalization. That is because 85% of the expenditure of a heart failure patient comes through hospitalizations abroad. Of course, we are figures abroad, but that could be true in India also. So major reduction in cost saving, and of course every hospitalization adds to the risk of mortality. And that's why any drug which reduces heart failure hospitalization, this is what ARNI did when it came in. This is what SGLT2 inhibitors are doing this way. And even the vericiguat, which is coming, also does the same, reducing the heart failure hospitalization. So the implications of continuing, we saw that if you don't give, patients are harmed. And if you don't continue, 35% increase in the risk of mortality in patient discontinuing GDMT. You feel, aha, patient's EF has improved. It was 25, now it's 45, his functional class improved. Then there is always a temptation to reduce the GDMT, especially because of the cost concern. But that is where this study comes into help, that if you reduce that or don't continue in proper doses, you can increase the mortalities. Again, discontinuation of GDMT increase the risk of readmission for Ffref patients. Discontinuation increases the risk of all-cause mortality in post-hospital hospitalization patient. The figures are quite startling for you to see. In a nutshell, initiation and discontinuation of GDMT keeps the Ffref patient alive and live longer, stands to reason because what we saw in the earlier slides today. So what is the GDMT which you could choose to initiate and continue? I have alluded to it already. The ESC 2021 guidelines recommend ARNI as a first-line cornerstone therapy for all Ffref patients. As I said, based on the patient's hemodynamics, blood pressure, heart rate, these things can change. You don't have to be stickler of the sequence offered here. If you are a good clinician, you will use all the 4 drugs to great advantage based on whatever sequence that comes to your mind best. And the new 2019 ESC guidelines have given 1A recommendation for the SGLT2 inhibitors. Same is true for the ACC-AH also. So we are now talking of 5 pillars of Ffref management, whether there is diabetes or no diabetes. So first pillar would be ACE, ARB, or let's say ARNI, because hardly ever we are using plain ACE inhibitors or ARB these days. So it has to be ARNI to start with. Beta blockers with or without ivabradine, MRAs definitely. So your prescription may not include a loop diuretic, but must include a spironolactone or a eplerenone. I prefer spironolactone because it is cheaper. Eplerenone at least 10 times more expensive and has very little advantage of less gynecomastia. And of course, it has become imperative to use SGLT2 inhibitors, especially dapagliflozin, in reduced EF. In preserved EF, we are tending to use more empagliflozin. So there is initiation evidence related to ERNI as a first-line drug, brings in remarkable reduction in mortality, remarkable reduction in heart failure hospitalization, and fortunately now we have Indian data about which we can talk of. So 20% reduction in the risk of CV death with ERNI compared to enalapril, irrespective of the glycemic status, and this being a diabetic conference, I have to keep saying that. I was actually quite reluctant to use the SGLT2 inhibitor in non-diabetics to start with, worried about hypoglycemia and other aspects, but I think it's quite safe. Now I'm quite a prolific user of these SGLT2 inhibitors. So the treatment definitely contains the 4 pillars which I was alluding to. And as long as the eGFR is above 25 to 30, you are safe. Because the heart failure with the eGFR of 30 will improve if you improve the heart failure. There is a lot of element of cardiorenal aspect. So rather than putting off by the eGFR, implement it in correct doses and you will find that eGFR improves because the heart failure is improved. So to summarize, go with the guidelines. Time is essential to start a guideline-directed medical therapy very early. Continue with ERNIs and other things with confidence, even if there is a borderline hypotension, eGFR low, and other things. And there is funny thing related to level of evidence. I like this slide and usually end my talks with this slide. See, if you look at the top, there is mathematics. And at the bottom, there is philosophy, God, rebirth, karma. This is typical Indian stuff, emotional stuff we talk of. And if you put the evidences like that, it is 1A. Mathematics is still 2 plus 2 is still 4. And philosophy is 2D. So you can keep talking hours about philosophy because nobody can question you on that. But medicine that we practice is 2B. That means it is fluid. What we talked 5 years ago may not hold true today because the evidence keeps changing. And that is where I stand today. Today, I feel GDMT for heart failure has really established itself with phenomenal results. Putting the 4 pillars and the side therapies like IV iron becomes very important for the patient. And we've had patients who have done remarkably well, have become absolutely normal individuals after few months of therapy. So the conviction has to be there. The knowledge base has to be there. The information is there in the books. That has to get converted to knowledge. And finally, wisdom will dawn on to us that if we implement it very well, we can do wonders to our patients. So I shall stop here. Thank you very much.
Trademark, and it's not without reason that you are known as a giant in cardiology, not just physically. So thank you very much for that. Being a cardiac surgeon, my understanding of all this high-tech stuff is quite limited. And to me, it looks like a real tight rope walk, the guidelines for treating these critically ill patients. I just had a very basic fundamental physiology question, probably bordering on stupid, that when people have a low ejection fraction, we tend to compensate for the cardiac output by increasing the heart rate. So how does ivabradine and beta blocker fit in this scenario?
The key word is rest. If you have a fracture, you put a plaster. So if the heart is sick, make it work less. So you reduce the number of beats per minute, and that will compensate by improving in the myocardial performance. That's what the principle is. Every angina patient, every heart failure patient shown very well by trials does best when it's between 60 and 65 per minute. So any critically ill patients, one would use inotropes and all, get the heart rate up. But for somebody's heart is sick and who is moving around is OPD management, heart rate has to be low.
Thank you.
Yeah.
Yes, I think every 6 months follow-up of a diabetic should include a NT-proBNP, is what I feel. That's a biomarker which will pick up before. Echo, I would say once a year. And ischemic, this thing should not be done, as I feel. But if you're, for heart failure, I think it's important to take NT-pro because it can diagnose incipient Ffref and Ffref as well. So every follow-up, every 6 months when a diabetic is coming to us for follow-up, in his list is included NT-proBNP. That has helped us a lot. And echo actually every year has other feature, again to pick up Ffref early. Ffref is easy to pick up because patient comes with symptoms and EF. And on this it works, all these drugs work. Yeah.
So that means actually when we do our guidelines for monitoring yearly, monthly, so I think this is an important thing to be included
Absolutely.
in the guidelines.
Absolutely, no doubt. Yeah, I'm not good at numbers in the sense I don't think it necessary to remember numbers because they're a bit. I use smartphones to do that well. It is not necessarily just by improving anemia because the ferritin improves. It improves the myocardial performance. That's how the IV iron only, not oral iron. And the carboxymaltose, which is designed now, it is meant for IV use, and it's very safe by way of reactions. Yes, answer.
So, how far hyperkalemia becomes a problem when you use lactose and RNA together? And does that prevent you from, how do you manage that? You just stop the drug? And I have another question is the role of LV assist devices now getting shorter with better medical therapy? Where would you put an LV assist device?
First question is about hyperkalemia. See, we know that this is GDMT and it has to be implemented in correct doses. And we are all astute clinicians. We should know that hyperkalemia counts. So every follow-up should have an electrolyte to be done. Above 5.5, I will start thinking that something needs to be done. The first drug to go off is a spironolactone, not ERNI, because the mechanism of action of ERNI is far stronger than the MRAs. And now there are K binders which have come up now, beyond K binder, and they are excellent. And we all would be using them on top of all this to prevent the hyperkalemia menace. The LV assist device is when purely the left ventricle has failed, right ventricle is intact, and even if there is, if there is significant pulmonary hypertension, the patient doesn't become a good candidate for a heart transplant because a new heart will not withstand the pulmonary hypertension. But if there is pulmonary hypertension, but the RV is good, then only to replace the LV with a machine, it is a left ventricular assist device. In last so many years of practice, I have had one patient of LVAD who also died. It's costing almost 1 crore of rupees. So it's good to discuss in such conferences, but it has little practice. Wonderful. CRTD device is when you have a Ffref with a LBBB, with a prolonged QRS duration of more than 150, that is the indication. And beyond that, it is all dilution. So you put in an expensive device, it's not going to help or marginally help, better not to put it. But all LBBBs with LV dysfunctions, which are beyond GDMT management problem, you must put in a CRTD. It's a rewarding treatment.
I think, yeah, excellent talk and very novel concepts which you have alluded to. Two things what Sanjay said. When we are about to now use finerenone, where risk of hyperkalemia is much lesser comparing spironolactone or even eplerenone. So I think that is a very promising drug, and especially when it comes to reduction fibrosis and inflammation, I think that is the best drug, which has the huge evidence of reducing not only long-term outcomes and mortality. So I'm sure down the line in 1 quarter, once this drug gets launched, it is going to be a standard care, and spironolactone should be out, seeing the profile of the drug. Yes. Second, left-sided cardiomyopathy is a known entity where what you refer to, that many times you put a device into left side, many patients, not very common left-sided cardiomyopathy, but of course reduced ejection fraction close to 15, 20 or 18, they will definitely benefit from these devices. And you very rightly said, when we were talking about low blood pressure and all that, that is how to us as diabetologists, SGLT2 are very, very promising drug today in management of heart failure, irrespective whether you are a diabetic or a non-diabetic, primarily because of 2 reasons. One is that heart blood pressure reduction is not very high, it is 4/2. We want to use it as a benefit. So if you are starting with a beta blocker and then adding SGLT2, maybe ahead of ARNI, you have that advantage. Hyperkalemia is not there. And best thing, what again you very rightly alluded to in your talk, that these days we are talking of heart failure hospitalization or composite heart failure with CV death, because we know 29 days, nothing else will work. No drug today which is to be launched, they can wait for 5 years to show the benefit coming out of reduction in mortality by atherosclerotic cardiovascular disease management approach. By hemodynamic approach, you can do wonders in 1 month time. So I think that way, SGLT2, that is why are coming up maybe as a standard therapy in these patients.
Even as a hardcore cardiologist, in my prescription, it has moved up.
Yeah, even in Delhi, we see Dr. J.C. Mohan is a close friend, and many times we share. And Professor Vijay Trehan is my Samdhi. You must be knowing him, director
Sir,
at Pant, cardiologist.
Thank you very much for your
Yeah.
comments. We're just kind of running a little short on time.
Yeah.
It's been a very, very interesting session and obviously reflected in the kind of questions that we've had. So thank you very much once again, Dr. Hirema. Thank you.
We have Professor Panikar. No, he's not there. So straightway we are moving to none other than Professor S.R. Arvind, a very close friend to me. He's like always an elder brother. And I can tell you, whenever he makes a presentation, it is going to be a different.
So very much. I think before I start, Hiremet is here. I mean, I don't really remember whether I played basketball with you. And it was here in Pune, I think, way back when you were playing for Maharashtra and I was playing for Karnataka, then in the Symbiosis campaign. I always thought you became a orthopedic surgeon for some reason, but then it was brilliant listening to you. So one thing is very clear, evidence-based, you know. Okay, so the evidence is very clear. 1A evidence, if you play basketball, you'll become good doctors. You'll become a good cardiologist at least, but I don't know about other things. I think we have a lot of things to catch up. Thank you so very much, Chairpersons, and thank you, Sanjay, and thank you, team of IDEC. It's been wonderful, and I really enjoyed the hospitality. And we were here at 12 o'clock midnight, and then still everything was there. I mean, we still had a good time till about 1 a.m. and then we are up here. And I don't know who asked me to actually talk about this gut health in diabetes. Can it be improved with diet? I think some guts you have asking me to talk about it. So I had to do a bit of research myself because I have not worked really on this field. So it's a shitload of work that has to be done, and well, let's see where we go. I think let's just start with the developmental charges. And what we know is the gut microbiota kind of changes from the time we take birth and as we age. And this is something that has been told to us, and we are comfortable with this. From esophagus to anus, and from C-section to vaginal delivery, the microbiome changes. Sometimes I feel you have no choice whether you are delivered by a through section or probably you had a normal delivery, vaginal delivery, because microbiome is supposed to change at that point itself. And as we grow, the changes can happen due to various reasons. You can do a number of tests about microbiome. You can take saliva, you can probably take some aspirations by doing an endoscopy, or you can also do some biopsies, or the best way, of course, is a lot of work with the poo, and this is exactly what people have been doing. The gold standard is to take the fecal matter and do all the tests, because that's still the gold standard. So it's a lot of poo. And we know that microbiota can be altered due to various mechanisms. Lifestyle can change it, antibiotics can change it, hyperimmunity, immunodeficiency, hygiene. It must have improved because of the COVID. And most importantly, the topic that we are going to discuss today is, can diet actually change the microbiota? That's a question. But before that, when I was making these slides, one thing that crossed my mind was, well, we do give a lot of antibiotics, especially 60-70% of the admissions in my hospital for diabetes is because of the diabetic foot. We do give antibiotics for 8 days, 10 days, 12 days, 14 days for foot infections. And then we just add a lactobacillus. Now, I wanted to look in and see how long do we have to give this lactobacillus? Is it 1 week, 2 weeks, 3 weeks, 4 weeks, 5 weeks? I did not get an answer. I will leave that question with all of you, if any one of you are students. What is the period of time that we have to actually give lactobacillus if we have used strong antibiotics for a period of 10 days and 14 days? Because we still don't know this thing. And I tried my best to see whether I can get an answer when I was making this. I didn't get an answer, so I leave that question to the audience. I think this is something that we all can search. Different things have given different things, and most of them said, you give it for a period of 6 weeks, and that's about it, because nobody has done any kind of testing on this. So we come back to the question about the diet and the microbiota. We know diet is the crucial regulator of intestinal microflora. Not just the diet, it's also about your genes, medication, and the diet. Individuals' age also has an impact on the microbiota. So in short, the gut microflora plays a very pivotal role in body's metabolism and immunity responses. Okay. And figure on the right here is only for Dr. Neeta Deshpande to just see and enjoy, and to give her an idea that I have done some work while preparing these things. Okay, otherwise you don't have to have a look at that particular picture at all. Okay, let's understand the good versus the bad. I wanted to make it look very complicated, and that's why that particular slide. You can't even see the names on that particular slide. Okay, there are thousands of bacteria and more than 3,000 genes or 3 million genes or whatever we talk about when it comes to microbiota. You have good, you have bad. You have hundreds and thousands of names in the good microbiota list, hundreds and thousands of names in the bad microbiota list. That's why sometimes it becomes easier when you actually take shelter from Mr. Shah Rukh Khan, because in Byju's, he says you have the advantage of 2 teachers. One to teach and one to teach you the concepts, okay? Now today I think we have a lot more of teachers here today, so let's just stick to the concept, because we all are clinicians. What we need to know is not how to do research when it comes to microbiota, but to understand a little bit more about what we know. This is a very simple cartoon. The red figure is fat. All that it's trying to tell us is somebody is obese, he has bad gut microbiota. If somebody is obese and taking unhealthy food, food rich in fats, food rich in sugar, or what you call as the junk food, probably you have a bad microbiota. And that can have an impact on various other problems. Somebody who is lean, because there is a lean phenotype and there is an obese phenotype. Okay, now anybody obese will have bad microbiota. In addition to that, if they have also junk food, it can actually worsen the problem. But anybody lean, here in the green, can have good microbiota. I mean, that's the lean phenotype itself. Later on, your diet plays a role and so many other things plays a role. So it's really that simple. You have good bugs, you have bad bugs, but they're all gut bugs. So you have to live with them. The food we eat affects our gut bugs. Thousands of species, 3 million genes. For you and me to understand very simply as clinicians, dietary habits play a very significant role in shaping the microbiota, providing substrates that basically determines the assortment of the metabolites produced. Very simple thing to understand. Some microbiota actually derive good metabolites. So good microbiota, good metabolites, and that has a positive impact on the host. Now, what are metabolites? They are nothing but molecular mediators. We can understand this in a very, very simple way. The gut microbiota is a crucial actor that can actually interact with the host by the production of a diverse reservoir of metabolites. Okay, in short, he is the prime minister, he is the home minister, he is the finance minister, he is the defense minister. So is a very, very crucial actor. So when once you understand more about microbiota, and when once we start getting more and more biomarkers to test, like Dr. Hirema did mention about NT-proBNP, because it's expensive, people are not doing it. So similarly, when once we have biomarkers for early diagnosis of a gut which is undergoing dysbiosis and a gut which is undergoing symbiosis, that makes the job very easy. I'm sure in a couple of years, we will have these biomarkers. And when once we have these biomarkers, we can diagnose early, we can use it for prognosis, and it can also help us to actually discover new drugs probably in the future. One step back, going back to your bad, in the red is the dysbiosis. 1 or 2 names is all that you need to remember. Clostridium difficile we know is bad. So if you have a dysbiotic gut, you have more of these bad bacteria. You have a symbiotic gut, what is in the green, like lactobacillus, you have good microbiota. You can also call them as Firmicutes for bad and probably Bacteroidetes for good. And there is a ratio of Firmicutes to Bacteroidetes. So from bad to good, you have a ratio. It's usually about 16:600 or something. One of the slides will also mention this. So when once you have more of harmful gut microbiota, they can also inhibit the good ones. Like, I was a good fellow, never wanted to drink yesterday and came at 12 o'clock. We had a bad bacteria in Dr. Sanjay who offered me a drink and made me a bad fellow. Okay, so that's a simple way of explaining how a bad person can influence a good person also to become bad. Or for those of you who are writing exams or who are planning to give lectures, very simple. Healthy microbiota has anti-inflammatory effects, antioxidants, they regulate the gut barrier, they increase the local immune system, they reduce entoxemia, and most importantly for diabetics, improves insulin sensitivity. Dysbiotic gut on this side, pro-inflammatory cytokines, IL-6, IL-10, TNF-alpha, everything has been increased in people with dysbiotic gut. Local immune response is low, they have increased endotoxemia, reduced insulin resistance, so on and so forth. So this is the concept that you have to remember. The red arrow very clearly tells you that if you have high calorie diet, high fat diet, sugary diet, if you are stressful, and if you are on antibiotics for whatever reason, you are moving towards a dysbiotic gut. If you are having a healthy diet, prebiotics, probiotics, and probably in future fecal transplantation, on the green, this one arrow, you are moving towards a good health. So this is what I was talking about. There are phenotypes of lean and obese phenotypes. It's got nothing to do with their food. Okay. And a number of people have already done the work, so we don't really have to go into this. So the lean phenotype are known to have better immune. Okay. So let's go and see how a dysbiotic gut actually worsens the problem. It increases short-chain fatty acids, increases the appetite. Now that's the problem. There are some people who say, I just can't manage my appetite. It's tremendous. I feel like eating 10 slices of bread or whatever it is. And some people can actually manage their appetite. So somebody with an increased appetite, for all you know, can have a dysbiotic gut. When once they have an increased appetite, they have an increase in energy absorption. And what's happening in a dysbiotic gut is, importantly, there is an increase in the SGLT1 expression. So the diabetes world is actually waiting for twin blockers, both SGLT1 and SGLT2 blockers. When once they're available, I think we should be able to manage a dysbiotic gut or probably reduce the absorption at that level itself. So what all can it cause a dysbiotic gut? Obesity, hyperglycemia, dyslipidemia, hypertension, NAFLD, irritable bowel syndrome, number of other things. Now, what is the evidence? Well, we have animal studies, you have human studies. And there comes Dr. Vijay Panikar. Thanks for coming early. Okay, so these are some of the animal studies, right? See, you always start with an animal study because it's not so very easy to do human studies. Very simple. You have germ-free mice and conventionally raised mice. Now, a germ-free mice is 40% lesser body fat. Vijay Panikar, GF is not girlfriend, germ-free. Okay, so just in case you're confused, so I just made it clear. Okay. Now, conventionally raised mice are usually a little heavier. Now, you transplant the microbiota from a conventionally raised mice to a germ-free mice. Within a week, there is a 60% increase in the body fat, increased triglyceride, increases in insulin resistance, independent of the food intake. So that means you don't really have to eat to have a bad microbiota or put on weight. Just dysbiotic gut, transfer the microbiota into somebody who had no germs. Now everything worsens within weeks. And a number of other studies also have been done on the animals. The important thing to remember is High-fat diet influences bacterocytes and the firmicutes ratio. High-fat diet also influences directly and indirectly the intestinal flora, the energy absorption, and the harvesting of this. Now let's come to the human studies, because we are all humans and we are interested in knowing what exactly happens. Fecal microbiota transplantation has been going on for almost a decade now. Different people have been doing different works. Now take the microbiota from healthy thin males and then see what happens 6 weeks later. Immediately there is an increase in the diversity of the microbiota, what you can see here on the top. Reduction in the short chain fatty acids, reduction in insulin resistance, increase in insulin sensitivity, and butyrate producing bacteria increases. They are good ones. So you transplant gut microbiota from healthy thin males to your subjects. This happens. Now, the same person also is the control. He takes his own microbiota from his own gut. Then the diversity of the microbiota currently comes down, short chain fatty acids increase, insulin resistance increase, insulin sensitivity comes down. So there is something about thin people and thin microbiota. Since Vijay Panikar stays in Mumbai, there are a number of actresses who are very, very thin with size 0. If there is a way of getting their poop, then see whether we can actually try it out and then see what happens. Okay, so I think that's not going to happen. People find it extremely difficult because measuring energy even through poop is a lot of work actually. So the optimal ratio between firmicutes and bacterocytes is 12:620. Now, interestingly, read just the last 2 lines. Don't go into the details of this particular study. Obese individuals, when they go on a low-calorie diet, which is considered as 800 calories per day, for a year, there is a tremendous decrease in the bad microbiota or the bad bacteria, and there is a tremendous increase in the good microbiota. And there is a 20% increase in the firmicutes, and this was associated with an increase in the nutrient absorption of about 150 kilocalories. So bad microbiota, when you increase, energy absorption also increases. So you put on more weight. So dysbiotic gut, people have more appetite, they eat more and then put on more weight. Now, 20% increase in bacterocytes was associated with a decrease in absorption of almost 150 kilocalories. Now, with all the evidence that we have with the diet, I'll come to the main thing. Can diet change the gut microbiota? Vegetarian diet has the best evidence, said to be very, very beneficial. Along with the other things, most importantly, the plant fibers encourage the growth of microbiota that produces short-chain fatty acids and improve your immunity, also anti-inflammatory. So the nutritional benefits and adequacy of a vegetarian diet must be judged individually. Sadly, Indian vegetarian diet is so different from the Western vegetarian diet. There are hardly any studies which has looked into microbiota composition of Indian vegetarian diet because it's so diversified. We don't eat vegetables the way a Westerner eats the vegetables. So somebody need to really do this kind of a work, and somebody like Neeta and group who are doing a lot of nutrition and dietary work, I think should start really working on this kind of a thing. It's very difficult to do these trials, expensive, but I think it's worth doing. The future directions, yes, at this point of time, probiotics, prebiotics, vegetarian diet, fecal transplantation. Not that the non-vegetarian food is bad. Well, pork is said to be something that actually pushes you into dysbiosis. Red meat, high in fats, high in calories, is known to push your gut to the dysbiotic gut. But if it's fish, if it's chicken, and with the right exercises, maintaining your body weight, you can still have a great symbiotic gut. So it's not that you had to stop eating non-vegetarian food, you just had to be choosy about what you are eating. So summary, the gut microbiota plays a significant role in maintaining the homeostasis of human health. We know the vegetarian diet is advantageous. And most importantly, people with metabolic syndrome and people with insulin resistance must start losing weight so that from dysbiotic gut to symbiotic gut. Weight loss can definitely reverse these dysbiotic changes. As long as we can sustain the weight that we have lost, it's going to be great. I think with time and better understanding, the correct therapeutic options will broaden. But at this point of time, we are not too sure what we are dealing with. There is good news for Dr. Hiremat about red wine. But we will not have the discussion, we will keep it for the night. Thank you so very much.
Thank you, Arvind, for a wonderful presentation as always. And as I said, I promised that he's going to put it in a different way. Everyone knew that there is a dysbiotic and a symbiotic combination and the concept, but the perspective in which you have presented was wonderful. And we have the experts, Dr. Neeta and Dr. Shilpa here to...
No, both of them have prepared the questions before giving me the topic. I know this. I know that they
So
do
you
that.
already know the answers.
No, I don't know the answers. You know, they would have prepared tough questions and
But
then they give the topic.
this was an online program, so they have obviously given you
Yes.
answers to rescue you.
So I just had two questions. I mean, they're rhetorical questions because there's no data yet. One is that it is known that excessive hygiene practices can actually diminish your good gut microbiota, like frequent washing of hands, drinking purified water, and all of those things. But considering that there's so much pollution, you can land up with very bad microbes and get really sick. So how does one draw the balance between that? That's number one. And second is, since our diabetes patients already have the consequence of dysmetabolism, should we routinely in the future think of prescribing prebiotics and probiotics to
I
them?
didn't find an answer. I also looked into one important thing, how exactly our oral hypoglycemic agents affecting the gut microbiota. And then there is some mention about SGLT2 inhibitors being good as far as the gut microbiota is concerned, but not much of work has been done. DPP4 has been neutral so far. Acarbose has been neutral so far, but SGLT2 probably is beneficial. There was no mention of sulfonylurea. So we don't know how the medicines are actually affecting the gut. Now, a cardiologist would also be prescribing at least half a dozen tablets, and we really don't know what is the effect of these drugs. Okay, coming back to your first question, I still don't know the answer because during COVID, I think we were keeping everything so very clean because we had no other choice. We were worried about getting COVID, death, etc., etc. But otherwise, all our kids have generally been crawling on the grounds and things like that. Now, I have become a grandfather with a 10-month-old granddaughter, and then we allow her to freely move around. And as long as, you know, the basic cleanliness of the house is maintained, what she touches and what she puts into the mouth, because we were told that's how you actually develop immunity. Okay. So it's a double-edged sword. Some moms are extremely careful about cleaning everything, and some moms say, okay, let them grow up the way they grow up.
Arvind, to be more precisely saying, it is SGLT1 which is important
It's
there.
going to be beneficial.
Which is going to be beneficial.
If
That
the
is how Canna has,
SGLT1 when it comes,
that is how Canna has some data that other than getting the extra glycemic benefits and some amount of extra reduction
of appetite,
microbiota is better with SGLT1
Correct.
inhibition. And she very rightly said, COVID has told us that is how we have scored much better than Caucasian and Western people because day one we have been eating everything and
You're very right,
Yeah.
Rajiv, because there are so many things apart from diet. You know, we are talking about aging, we are talking about genetic makeup. There is so many things influencing microbiota. We really don't know.
We always were consuming fecal transplants naturally. Yeah.
I really can't think of or even
Yeah.
imagine a fecal
Unfortunately,
transplant.
fortunately, which has made huge difference to our immunity.
I find it very difficult how they do this
Yes.
poop test and, I mean, how do they infuse it? Okay, we'll not talk about it now.
Shilpa, you wanted to? Any comments? You've been an expert on that field, no? Okay.
I have one doubt.
Yeah.
How do we reply or how do we analyze these East India gut issues? So there's a very distinct problem among
There's,
East
there's,
Indians.
except from the National Institute of Nutrition, Hyderabad, there's hardly any trials on Indian people with diabetes. This is what I was talking about. Now, RSSDI or organizations should really look into this and take it up as a priority and do it at the level of RSSDI, not give it to a postgraduate student or anybody, but you can actually put up centers. Let's do this kind of work. Let's see our Indian food. It's so diversified. India changes every 100 kilometers. Your language, your habits, your food, everything is changing in India. And we really don't know what to do with this microbiota. And this, trust me, will be sometimes a major question in the examination. Gut microbiota, that's it. And even the examiner will not know what answers or how to tick this one. Everybody nods their head then.
Fine. Thank you, sir,
sir.
for a
Thank
very,
you so
very
very much.
informative talk and your incisive humor.
So, Dr. Panikar, I think it's your turn. Arvind has already said thanks to you for coming late. So, without wasting any time, we'll straightway go to your session. Professor Panikar needs no introduction on any national.
Good morning, ladies and gentlemen. At the outset, let me thank Neeta, Sanjay, and the entire team for having invited me to give a talk on parameters of longevity. And do we have the Holy Grail? Yeah. It's something, you know, there are a lot of paradoxes in medicine. Dr. Arvind gave a wonderful talk. He said you eat vegetarian food and your gut will improve. You know, I know friends of mine who come from the US who have been there for 10, 15 years. When they come with their children, my God, they want Bisleri water, they want this, they want that. And thoda bhi kuch idhar udhar kiya ki they'll get loose motion, they get vomiting and they're sick because they have no immunity. अरे अपन तो जाके पानी पूरी खा के आता है, वो भैया किधर से डालता है मालूम नहीं, but that is what gives us the immunity. Now that is what the paradox is. Now let's see the parameters of longevity. Holy Grail. What is Holy Grail? It's supposed to be that it carries the elixir of eternal life. That's the Holy Grail. It's the ability to give long life. You know, like they say in Amrit, कि you have Amrit and marega hi nahi. That kind of thing. It's a fountain of youth. You will always remain young. But this is a myth. We are all going to, who are born here, will die. Life expectancy as birth has risen. Initially in India, early days, in the early 19th century, I think the average age of death was 40. People used to die of smallpox, cholera, famines, epidemics. Now all that is controlled. Infective diseases are controlled. Vaccinations have come. And people are becoming healthy. Today, average Indian lives up to 70, 75, which is excellent. But it has its own consequences. So basically, abroad, it has gone up to 80, but the death remains more or less the same nowadays. So why do scientists want to see us stop aging? Because what aging does is, the reason is that they believe aging is the single biggest risk factor for diseases such as cancer. As you age, you get more cancer, Alzheimer's. In fact, yesterday I saw a very senior pediatrician, one of the topmost pediatricians of Mumbai, was admitted under me in Lilavati. He was my patient with diabetes. He's demented. He's just 82. I mean, wonderful human being, but his dementia. His hands were to be, see, his hands were tied down because he was pulling out everything and he didn't even recognize me. Now, that is the impact. So you can get cancer, you can get Alzheimer's, you can get diabetes, you can get all the other complications that comes. And these conditions were less of a concern before public health initiatives like clean water, vaccination and everything, and now we live longer. So now these things are coming to the fore. So when you talk of a lifespan, whoever is born is going to die. And from birth to death, that is his lifespan. And there is something known as a health span. Health span is a period of time when we are healthy until we die. So that is the difference. You have to look at the lifespan and a health span. Can I have the slides? Nahi aa raha hai? उसने मेरा माइक घुमा दिया बट स्लाइड नहीं आया
Laptop display?
हाँ
Laptop display is there.
या डिस्प्ले Okay. All right. Then I'll continue. So basically what we look at is lifespan and the health span. Now, as life progresses, at one point of time, the health starts deteriorating. And that is known as the onset of morbidity. And this point of shift, which is known as onset of morbidity, comes as you age. And on an average, it's about 55 years of age when the onset of morbidity sets in. And then diseases like cardiovascular disease, stroke, osteoarthritis, type 2 diabetes, dementia, Parkinsonism, movement disorders, and all start setting in. So most illnesses that we suffer from are chronic in nature and generally occur much later in life. The infective ones are earlier, but these are chronic, these are debilitating. Now, the basic concept now is, can we compress this morbidity? Your morbidity begins around 55. Could you compress this morbidity and increase the healthy lifespan beyond 55? So increasing longevity without increasing our health span would have serious economic consequences, because as the lifespan increases and our comorbidities increase, it becomes a major health problem, financial burden on hospitals, societies, and the families. Taking care of invalid old people is a problem. the disease, treat the disease. If somebody has diabetes, you treat his diabetes. He has hypertension, treat his hypertension. Dyslipidemia, treat his dyslipidemia. And hopefully this will result in a longer lifespan. And we definitely have evidence for that. That if you adequately treat diabetes, hypertension, dyslipidemia, you can increase the lifespan of that particular patient. Oh, wow. Now I can be seen at least. अभी चालू हो रहा है कि टाइम है?
Everyone was able to hear you online. They were not able to see you. That was the
या नहीं, वो तो इसलिए तो लाइट आ गया तो अगेन हाँ ठीक है ठीक है. So what's happening today is that with modern medicines, with modern treatment for all these conditions, I mean, you have a coronary artery disease, you do angioplasty, you do bypass, you do redo bypass, you do redo angioplasties, and you can prolong life. But prolonging life or living longer, we have opened ourselves to different suffering. Because since the onset of morbidity remains on an average 55 years of age, which has virtually remained unchanged from 1980 onwards. So, just prolonging life is not the question. The question is how to have quality life. We still don't have this. So the compression of morbidity, this theory states that most illnesses are chronic, which occur later in life, and it has been postulated that the lifetime burden of illness could be reduced if the onset of chronic diseases could be postponed. Like for example, if somebody is likely to become a diabetic by 40, he takes necessary lifestyle precautions, diet, exercise, weight reduction. He can postpone the onset of diabetes from 40 to maybe 50 or even 60 or even prevent it. We have diabetes prevention studies which have been done. So that is where आ गया. हाँ, ठीक है. Illnesses are chronic and occurred later in life, and postulated that the lifetime burden of illness could be reduced if the onset of chronic illness could be postponed. And if this postponement could be greater, that increases the life expectancy. Now, this is a schematic appearance of it. If you look at it, 55, 60, 60 is there, and that triangle that you see, morbidity begins around 55, 60, and death is 70, 75 to 80. Between that period is where all these chronic diseases come. If we can shift that morbidity from 55 to say 65 in the last thing, the healthy period of life improves. And if the healthy period of life improves, the further period could still be better. The chances of getting all those chronic problems could be much less. So as people live longer, some fear that they will spend additional years in poor health, disabled and demented. In contrast, the compression of morbidity hypothesis posits that people can have both a longer life and a healthier old age. That is the crux of the matter. To do so, it is necessary to postpone the onset of morbidity. So main thing is to postpone the onset of morbidity, which generally begins around 55. If you can push it back through healthy preventive practice, and more rapidly than death is not going to be postponed, but you can postpone the morbidity. So while it is true that good preventive medicine, healthy lifestyle can postpone disability due to chronic diseases, there comes a stage in every person's life that significant illness-related debility is experienced. As you age, it is eventually going to catch on. But how much does it catch on? To what extent does it get in? That is where your compression of morbidity will play a role. As the illness progresses, it becomes a source of bio, psycho, socio-spiritual suffering. Now, what is really aging? Aging is a persistent decline in age-specific fitness components of an organism due to internal physiological deterioration. And aging results from impact of cellular damage over time. This leads to a gradual decrease in physical and mental capacity, a growing risk of age-related conditions, and finally death. Aging is a process that is different in every person, and it's a lifelong process. Actually, aging starts from the age of 20. From 20 onwards, your skeletal muscles start using less energy, get stored more in the fat. That is where it starts. So you need to start early to have a healthy lifestyle to shift your compress your comorbidity. We should remember caring of the individuals, keeping this in mind. So aging is a complex process. Physiologically, aging is an accumulation of damaged and mutations at the cellular level, which drastically decrease the function of our tissues and organs. One of the most obvious manifestations of this dysfunction is a loss of skeletal muscle. Most important. Skeletal muscle, which typically takes a gradual decline after the age of 45. So there is a sarcopenia, and that is where the weakness comes, because the muscle is going. I'm not talking about the comorbid conditions like diabetes, hypertension, I'm just talking about a normal person who is aging. So the loss of muscle mass and strength that occurs with normal aging is referred to as sarcopenia. And why does this happen? And this leads to a lack of balance, lack of stamina, inability to walk properly. All these things come in with loss of muscle mass. And why does this happen? It's because of lack of proteins. But there is a plus factor here. There is a silver lining. We could change this. And how do we change this? Why do you get sarcopenia? Lack of exercise and lack of proteins. And if we give adequate protein and adequate exercise right from the beginning, you can make a huge change in the outcome. So when you talk of protein intake, Dr. Arvind said, vegetarians have good, but vegetarian protein is not up to the mark. The biologically superior protein is your animal protein. So basically, generally we all say, 1 gram per kilogram body weight is the requirement, but in these elderly you can give up to 1.2 grams per kilogram body weight. And giving that is a difficult proposition, because in vegetarians it becomes difficult, but you can have protein supplementation. That is the easiest way to give them protein. And among this protein supplementation, whey protein, which comes from milk. Whey protein is a milk-based protein casein, which is good, and it has been shown to improve the muscle strength and muscle integrity across the board. So basically, achieving this kind of protein intake can be daunting, because vegetarians hardly have any protein. So you have to give a supplementation. Nowadays, you get good whey protein powders, which can have in a scoop up to 15 grams of protein, which can be given twice or thrice depending on his need, which can cover, an average person would need about 60 grams of protein in a day. If his diet is inadequate, supplementation can be done with a whey protein. Now, aging gracefully is most important, that you have to stay physically active. A lot of studies have told us across the board, I won't go into the details, that exercise is the best. In fact, I tell my patients 40 minutes exercise. Like, somebody who comes to me who is now, say, 55, I say, तुमको और 5 साल बचा है. हाँ, 60 होने के लिए 5 साल बचा है. Basically, when I tell them, you go, sir, doctor, time नहीं है मेरे को टाइम ही नहीं है. मैं बोला, टाइम तो मिलेगा तेरे को, अभी 5 साल बचा है, 60 होते ही बुढ़ापा शुरू हो जाएगा. और तब अगर फिटनेस है ना तो आगे के 25-30 साल हंसते खेलते जाएंगे, नहीं तो भीख मांगना चालू होएगा, मुझे पकड़ो, मुझे उठाओ. This is ground reality. And this is the crux of the matter. And trust me, when I tell this, and my associates also tell this to the patients in the same tone and tenor, it makes a huge difference. And they realize that what I'm telling is a fact. And I tell them कि मैं जो बोल रहा हूँ ना उसमें आपका एक नया पैसा खर्चा नहीं है, फायदा ही फायदा है. खर्चा तो खाली मेरे एनर्जी का और आपको बताने के लिए. So that sets the ball rolling, and it makes a huge difference. Trust me, I have seen people who are, bad, down, they really come up. So physically active is the most important. And a lot of studies have shown that regardless of age, having a physical fitness is worthwhile. This fear. Regular exercise, what you need is about 2.5 to 5 hours per week of moderate intensity exercise, 1.25 to 2.5 hours per week of vigorous aerobic, and a combination of two. Basically what I tell my patients is go for a 40 minutes walk. You should do at least 150 minutes every week. 40 minutes walk, and you do 10 minutes of some resistance exercise. You can get some spring or rings or bull worker or dumbbell and do some uthak baitak. And along with this, what is needed is mobility exercises. Flexibility, bending, getting up, and balancing. Especially in the elderly, you find that they have a problem. So these are the exercises that need to be given to them. Mental health is very, very important. Very important. You should spend time with, you should have friends and family. I have a lot of friends who have the pica syndrome. Pica syndrome is not the iron deficiency one. It is parents in India, children in America. And I have seen there is a depression with them. They have not accepted the fact that they are alone. And that makes a big psychologically deterrent to them. They're depressed. They lose their initiative to do anything active in life. So what you need is a good set of friends, good family background, which helps a long way in giving you a nice, healthy old age. That family support or relative support is very important. Now, there have been certain drugs which have looked at aging. Rapamycin, which is basically a drug which is given to organ transplant. And what they showed that in mice, they lived longer and were healthier. And that's very impressive. But then, they also suffered serious cataracts, testicular atrophy and things like that, which is out. Then, Arvind showed about red wine. Red wine contains resveratrol, which is from the skin of that red wine, grapes, and which has been shown that it could be used as a longevity drug. The French were very happy because the wines would sell. Red wines, French wines are the best. But then, if you have to really get the benefit of that, you are going to land up with cirrhosis of liver. You'll have to drink that much of wine to really get the therapeutic benefit. But this drug, metformin, has had a good track record. It has shown that in diabetics, it reduces the risk of cancer, reduces the risk of coronary artery disease as shown by the UKPDS study. It has many other beneficial effects. It can possibly, it's weight neutral, but could help in weight reduction. The diabetes prevention program has shown that it can work. And it is a drug which has been used for donkey's years and in millions of patients, and hardly any significant side effects except GI side effects. Metformin has also been shown to reduce the risk of dementia in patients with diabetes, but this is not really approved in a non-diabetic. Diabetic will obviously give metformin. But now they are looking at whether you could give metformin to elderly patients to make them age gracefully. Prevent all these complications like dementia, cancers, and things like that. So there have been studies which show that it has an anti-aging property. In animal studies, especially in roundworm, what they find is when the roundworm is getting old, it shrivels up and dies. But if that roundworm is given metformin, it doesn't shrivel up. It is nice and healthy and lives much longer. And this has led to studies which probably show that metformin could increase the longevity. And there are some studies which are in the pipeline. This is the TAME study, targeting aging with metformin trial. And this is being done in the Scandinavian countries. They have probably got about 3,070 plus individuals, non-diabetics enrolled. They are giving about 1,700 milligrams of metformin to them daily. And they are going to see whether these patients, what happens to them over the years in terms of developing cancer, in terms of developing dementia, in terms of longevity of life, and general health and well-being. So this is in the pipeline. And so if you look at metformin, it can treat diabetes, possibly dementia, cancer, Alzheimer's, heart disease. That is what today we are looking at. But we don't know. This is all in the pipeline. We can always dream of something good happening. But this is a drug which is absolutely safe that way. So the takeaway would be, see, getting old is part of living. You are all going to get old. But it is not the length of life that is important. It is the quality of life. So your comorbid situations begin around 45, 50. And if you can keep your system good right from day one, your exercise, diet, fitness, you are going to change that comorbidity, you'll compress that comorbidity, extend it from 45, 55 to 65. And that will give you a good health span of life. Lifespan will remain where it is, but health span. And that is what is most important. So our goal in gracefully aging should be to improve our lifespan, but to improve our health span. Today our society, there is overconsumption of everything. See, when I was a student, we didn't have food. We only had ration. There was no McDonald's, there was nothing. You could not buy rice in the open market. But today there is plenty. And that plenty, you just ring up Zomato and you get what you want at 12 o'clock at night also. Because when my wife makes horrible food, that is what I do. So that is what life is. But there is a overconsumption, and the right quantity of food and the right food is hardly being taken. So the benefits of consistent exercise cannot be overstated. Make conscious effort to exercise regularly. Remember that aging is a marathon, it's not a sprint. It's a marathon. You have to be slow and steady. And consistency is the key. So slow and steady wins the race. You inculcate this habit of fitness, a good protein diet, weight reduction, and you will live a nice, healthy, long life. Thank you very much, ladies and gentlemen.
Thank you very much, sir, for a very, very informative medical and philosophical talk. Very practical points of how to live longer. If there are questions from the audience, they're most welcome.
Yes.
See, whenever you start, you will get the benefit. So it is not that you have to start at 20 and you can't start at 70. There are enough studies which have said that even a 70-year-old who starts exercising, who starts having a diet, shows a good improvement in terms of his muscle strength, in terms of his social life, in terms of his positivity in life, everything improves. So that is there. As far as when should we start, you can start today. Exercising is not a taboo anytime. And walking or exercise is part of life. So you need to put that into your lifestyle. That's it. See, there are a lot of studies which looked at antioxidants, at vitamins, vitamin D, and so on. But nothing is in the pipeline showing any real benefit. The benefit which has been shown is by compressing that comorbidity. Lifespan around 75, 80 has been there for now many years. We have not been able to increase that lifespan. And quality of life can improve by compressing that comorbidity. That should be the take-home message. That you are going to get old, you are going to die. But you should die nicely, style mein. That is what is important.
I think we will have to close. Wonderful.
One question.
Okay. Any comment?
It is definitely used in PCOS patients, not in thyroid. Yeah, no, PCOS patients, metformin is definitely a treatment. It reduces insulin resistance, and that is how it works in PCOS. But in thyroid, it is no role.
I think I take it as words of wisdom coming from one of the most seasoned teacher in this country. And very rightly said, it is not about longevity, it is, I think, the health span which is much more important for Indian sarcopenic patients, more so diabetic. I think it is diet, exercise, lifestyle, which will go a long way. Forget about drugs.
Thank you.
That we go to the last session, which is by none other than Mithun Bhartiya, a very close friend, a wonderful orator, and he is going to take you through the Indian real-world data on oral semaglutide. I think I must congratulate you. Yesterday only his abstract has been accepted in IDEC, maybe one of the first data from this country. Mithun, please.
Thank you, sir. So I thank the organizing committee for giving the opportunity. And as Sir has said, that it's been accepted in IDF. It's a multi-centric data on oral sema. Now, we are all aware of oral sema. That's the first oral GLP-1 that has been there. And the prescribing information, you start with 3, after a month you go down to 7, after a month you go down to 14. How much of that is practical, how much of that is realistic is something which we're going to look at and all of us decide. So what we looked at multi-centric data from quite a few centers in India, cutting across geographical boundaries, to look at the efficiency and safety, mainly efficiency, because safety you cannot see in 1 and 3 months, in 1 month and 3 months, and see what we were. We kind of excluded all type 1 diabetic patients that were there, and adult patients is what we actually looked at the data, whoever initiated on oral semaglutide. Now, sorry, no, I skipped there. We looked at retrospective data from the author's clinic, analyzing the effect, and the mean duration was 3 months from baseline. They received treatment as standard of care, because standard, real life standard of care is very different to what we encounter in research or experimental studies where things are very different. In real life, people stop their medication for a few days, something else happens, a lot of things come in, and that is what we live in. That is what we are, and it's important to see how that has an effect on our body. So we looked at the weight, the blood pressure, fasting PP sugar, AST, ALT, and urine ACR at baseline and 3 months. Now, this is very important. Chawla sir is a part of our group, so it's very nice that he's chairing this session. And we looked at across India. We had Dr. Pankaj Aneja from Delhi, Dr. Rajiv Chawla, Dr. Makkar sir, Dr. Arun Pandey from Lucknow, Dr. Bansi Sabu, Dr. Jyoti Dev, Dr. S.K. Singh from Patna, Dr. Debashish Basu, Dr. Devmalya Sanyal, Dr. Anirban Majumdar, Dr. Somirbata Roy Chaudhary from Calcutta, Dr. Sunil Kota from Berhampur, Dr. Sambidas from Odisha, and Dr. Subhas Kumar. So we kind of tried, because as sir was saying in the previous presentation, if you have it from one center, maybe there's a geographical bias. So let's see what happens if we're cutting across a bit of geographical lines to see what's happening. Now, in the prescribing information says we start with 3 milligrams and then you upgrade after a month. But we found, based on clinical practice, clinicians' practice, only 76% received a prescription only for 3 milligrams. Rest 24% started on 7 milligrams. Now, could be a reasons that they moved from another GLP-1, or they found that 3 milligram would not do the desired effect for practical benefits. And even though they were started, the titration was much faster. So even titration from 3 to 7 after 30 days was recommended, 38% up titrated dose after 10 days, and 26% after 20 days. So maybe left them for one, because it comes in a box of 10. So left them either one box and moved up to 7, or 2 boxes and move up to 7 that were there. This were the initial results in 4 weeks. So we looked at the mean age of patients was 53 years, and 179 patients with that. It started accumulating after that. So we looked at glycemic parameters and body weight BMI, and we'll look into that individually. If you look at glycemic parameters, it improved, with the fasting improved from 169 to 114. There was a drop, and PP from 229 to 147. There was a decrease in body weight around 2 kilograms in the first month, and the BMI decreased marginally as well. The blood pressure decreased very transiently from 138 to 132 and 83 to 80. This was now the follow-up at 3 months, which we looked at. The mean age was around 50 years. More people were there now, 224 patients. And we looked at glycemic and other anthropometric parameters, which I shall compare to what actually the data from the Pioneer showed, so that we know what it showed and what we have, and is there a discrepancy, and what are the reasons that could be for the discrepancy. Now, oral SEMA has shown benefits of around 1.5% in all their trials as an average on 26 weeks, which is roughly 6 months. So we don't have 6 months data, we have 3 months data. This is what we have, and this is what we'll see. So if you look at 3 months, there was a drop of fasting from 179 to 116, PP from 236 to 141, and close to around 0.8% drop of HbA1c in 3 months' time. Maybe we are following our data. More people have joined in already. So we'll have 6 months data very soon, and we'll see what that shows. Now, in terms of weight loss, the oral SEMA across the trials have seen average around 5 kilograms of weight loss across the Pioneer trials. In our cohort, we had around 9.5 kilogram weight loss over 3 months, and decrease in BMI that is there. If you look at blood pressure, there was slight improvement in systolic blood pressure and slight improvement in diastolic blood pressure. If you divide this cohort into baseline HbA1cs that were there, as we know, if you have a higher HbA1c, the chances are you will drop more. So that's what we found. Patients who had higher HbA1c got more benefits than patients who were, less or tighter HbA1c that were there in terms of the drop of the HbA1c. Now, if you look at the subgroup analysis of Pioneer trial, it shows that it reduces HbA1c and body weight in patients with T2DM, regardless of background glucose lowering medication. So what we are going to concentrate now is on SGLT2. So even if they're on SGLT2, it reduces HbA1c, and there is no difference with and without that is there. So let's look at what we did. We divided our cohort of 3 months with SGLT2 and without SGLT2, and looked at whether there was any difference. And we found even that there was no baseline difference in the characteristics of the group, and the improved glycemic profile was found in both the groups, with SGLT2 and without SGLT2, with no significant p-value that was there. So saying that it didn't really matter whether the patient had another combination, specifically looking at the glycemic parameter. However, there was a better benefit that we found in patients who, in their blood pressure, who had a combination with SGLT2, and the p-value was a little significant in systolic and diastolic blood pressure. There was the body weight and body mass index, there was no significant difference between the two. If you look at urine ACR, urine ACR is very important to look at because in the Pioneer trials, they never looked at urine ACR with and without SGLT2. And we found that there is a benefit if you combine that with SGLT2, the urine ACR reduction is better. In patients without SGLT2, there was a drop from 84 to 60, and patients with SGLT2, 104 to 68. There was an improvement in AST. There was no difference in ALT in our information that was there. So overall, that we found that though this is preliminary data, I think it's a first attempt to have a multicentric data across boundaries. And we are going to look at 6 months and further down the lane at 1 year. We're coming with an app also to store data so that it's easier to store the data and easier to see what's going on with the population. The other thing was a distinct thing that I notice in my patients is that patients often complain of a sour taste when they put the oral semaglutide in their mouth. That could be because of the molecule or because of the snack. So what I advise my patients is that I ask them to gulp a little bit of water because there is more natural lubrication. So the contact time of the tablet to the tongue is less, and so the foul taste is kind of obliterated in those patients. With that, I end my talk. Happy to answer any questions.
Available on oral semaglutide on Indian ethnicity. And of course, molecule is very, very promising. The results not only in terms of glycemic control, but weight reduction and extra glycemic benefits are going to be very, very promising. Thanks a lot. Any questions or comments? Okay, thank you.
Thank you, sir.
Yeah. The last session, which is by Dr. Saurabh Mishra, and he's going to take us to a journey that how to counsel a patient for insulin pump, which in itself is a art. It is more of an art than a science.
So first of all, I would like to thank all the team of IDEC, Sanjay sir, Archana Sada ma'am, Dr. She's not over here, and all. I think so last session, I thought it was very interactive, and I will make it very nice one. So let us think with the pioneers, all Dr. Pandikar sir, Dr. Rajiv Chawla, everyone is over here. So I can just tell what I am doing at my part. So just as base, I think so, of insulin pump, we all have heard about insulin pump, and insulin pump therapy at present in our country is also roaring. All the people who are practicing diabetes, they have always a dream to start insulin pump in some of the needy patients whom when insulin high doses are going on, type 1 people. So just laying down the basic stones about insulin pump therapy. These are some specific words, specifically tips for successful patient and physician experience. What is specifically, what we can share with the person who is using pump, what he comes to us, what is his considerations about pump therapy. He thinks now I am using this therapy and accordingly now I'll be a non-diabetic. So a realistic approach towards this science has to be progressed because this is artificial intelligence and it is leading the world and we have to insulinize the people. So the good physician treats the disease. The great physician treats the patient who has the disease. And These are some important words which we should keep while prescribing any therapy to our person. This was a design of the first insulin pump which was installed, and nowadays we know the insulin pumps available. There are some fashion shows also going on with the insulin pump wearing, and each and everyone who has the pump, and all the type 1 children who are progressing towards, we have insulin pump education programs. So it is now a dilemma of insulin pump display. Then this has been the history all throughout of insulin initiations, the devices, the technologies, the AIs, the artificial intelligence which we are lying at present 2022. So the expectation again increases, but the recommendations made for insulin pump therapy will always remain the same. The continuous subcutaneous insulin infusion is justified for basal and bolus insulin therapy in people with type 1 diabetes. Only providers who practice can assume full responsibility for the comprehensive pump management program should offer this technology. Because I have been seen since past 12 years, I have been offering this technology, and in my state, I have reached about 100 people who are using insulin pump therapy, or you can say artificial pancreas, which nowadays is. But all throughout the journey of 12 years, this is my experience, if we are not evolving a proper insulin therapy team at our center, which includes a physician, a trained person who is known as insulin pump technician, a nurse and educator to handle these people, because these are device related. There are many issues which in further comes in logic, and it is not logical to manage everything. So we should develop a team. Appropriate patient selection is necessary and must include thorough assessment of patient's knowledge of diabetes management and other principles. Now, ideal candidate is a type 1 person, intensively managed in insulin-dependent type 2, then currently performing more than 4 insulins a day. This has to be taken. He must be on MDI. That it is not right away on the first go we are offering an insulin pump therapy. And if he is type 2, then also he must be having a higher units of insulin consumption, more than 100. And he is having a realistic approach of doing SMBG approximately 4 times a day. So these are the right candidates to be chosen for pump therapy, which will not discard the therapy within 6 months. They will not come back and say, Doctor, तुमने मुझे फंसा लिया, ये क्या तुमने मुझे पकड़ा दिया. If you are achieving a particular patient, you have to make in consideration, is he fit for the therapy or not. If he is not fit for therapy, don't give this insulin pump therapy. Otherwise, it will be not be a boon to him. It will be a curse to all the system and the society. So the choosing the right patient is very much necessary now. Now, willing to maintain frequent contact to the healthcare provider and your team and education which you are giving for insulin pump therapy. Pump use in hospital settings, this has to be taken in count. We have in our emergency room, ye tamjam hata do. It is illegal, medico-legally, you will be sued for doing this for a type 1 person. So there are certain guidelines which we have to follow. We don't have Indian consensus, but this has been experienced by me, and I was very much annoyed by a physician who just discontinued the pump for a simple procedures. So at emergency room or the hospital administration, should the patient not be able to manage his or her pump, the specialist responsible for the patient's ambulatory pump management should be contacted promptly and make decision about infusion adjustments. Hospitalized patients and their admitting physicians should encourage not to discontinue the pump infusion and should consult the specialist as needed. Now, these are some recommendations by AD, American Diabetic Associations. They say that if there is a critically ill patient whom you want to, you have to treat in ICU, then you have to, transaction of this insulin pump has to be on IV insulin. And if they are undergoing some surgical procedures more than 2 hours, then also you can just shift them onto the IV insulin infusion. If not, if the procedure is less than 2 hours, you need not to change the pump. You do not have to discontinue the pump. Just you have to take certain precautions for that. For X-ray, the pump should be covered by a lead apron. For MRI, the pump and the material of infusion should be removed because it is having metallic contents. Then in ultrasound, there is no need of removing the pump. Just do not, the probe should not be pointing the pumps, otherwise there are some settings which can be distorted. Then cardiac catheterization, the pump should be covered by an apron. Then for pacemaker implantation, AIDs, the pump should be covered by a lead apron. Then for colonoscopy and laser surgery, the pump should remain in place. So these are some procedures which we should see. Now, what is the role of the physician? The physician's role is insulin adjustment, basal rate testing, bolus type guidance, correction formulas. This have to be educated to all our type 1 persons or all type 2 also who are taking. So carb calculations, insulin sensitivity factor, carb to insulin ratio, correction ratio, the small setting, not more than 15 to 30 minutes it takes in local regional language to explain how they can calculate their insulin sensitivity factor. Then avoiding overcorrection of each and every hypo and hypers. Pump and exercise has to be trained very properly. Hypoglycemia is specifically seen while vigorous exercises. So if you are going for vigorous exercises in pump settings, the basal rate for infusion of insulin delivery can be adjusted a little bit on lower side. Then cannula site examination is very much necessary. What a physician must see in the basal review, only 3 things. Whenever you hold the pump of a person, you will get a basal review. You can have a bolus history and the priming history by which you can yourself know about your person whom you are treating, how much effort he is giving. Now, 5 principles to remember specifically. Every meal to bolus has to be done. Choose a right bolus type. Keep 3 hours or more gap between boluses. Avoid frequent correction of and thus insulin stacking. Then treat hypoglycemia with only 15 to 20 grams of glucose as recommended. Now, patients to follow these 5 rules for success. Chain cannula within 72 hours. In our Indian settings, we are not doing the same. So the insulin pump therapy is not giving the result. Sometimes the dose is increasing. There is stacking also. You have to change the cannula every 72 hours. Now, rotate the cannula site insertion. SMPG, self-monitoring of plasma glucose, is very necessary sometimes for the corrections. Then each meal and except excise carbs should not be covered with insulin. Never suspend the pump more than 1 hour. This was specifically for those pumps which were till date available and we were not having this artificial pancreas. Now, as we are having this 780G, the system has changed. Before prescribing this insulin pump therapy, so pump first or CGM. So start with the CGM to know about the glycemic variability of that person, which helps in fine-tuning and insulin needs. Then add the pump to your therapy. Now, what are the specific CGM at present in our? We have this CGM Professional, then we have this Abbott Freestyle Libre, Flash Personal Continuous Glucose Monitor, we have Medtronics, Guidance, then we have this Gluconova at present, with Circa, which shows this type of display over the mobile. Now, and we are entering into a digital diabetes era. What is this digital diabetes era? These are some dreams which are coming true all throughout. These dreams are not far at present. Since January, we have been having this artificial pancreas in our armamentarium, and we have implemented it to those patients. What they say, Doctor Sahab, aapne mere pankh laga diye. They are, each and every bolus is being given artificially by self-monitoring of these algorithms, and this is a governed pancreas. So artificial pancreas works in this manner. There is a continuous glucose CGM sensor, then that senses and gives the data to the receiver, which is having its algorithm. Then algorithm, accordingly, it is directed towards the pump, and the pump infuses the insulin as so required. Now, this is a bionic pancreas. There is a difference between artificial pancreas and a bionic pancreas. In a bionic pancreas, there is a continuous glucose monitor which senses the hypos, and at the time of the hypos, there is a glucagon pump also which infuses the glucagon, and accordingly the hypos are managed, and then further the continuation for the pump is there. Now we are having some smart, more bionic pancreas available. Might be this is the future for bionic pancreas in the world, and specifically this is one of the bionic pancreas which is coming into be in commercial markets also. This is being developed by a father who himself is a doctor, and he is making this bionic pancreas for his son. So now the dreams are not very far, but at present this dream has become a success in our country, and we have been prescribing to many of them. So I have approximately used 2 of these pumps to my people in my state, and they feel that, Doctor Sahab, aapne mere pankh laga diye, now I'm very free. There are algorithm-based studies, and according, now the main topic comes. This is how it looks like. Each and every type 1 child of R who is being managed on MDI, this is a dream for them, but the cost of the pump, the pharmacoeconomics in the country at present is serving a very great problem. The consumption, the overall using and the uses is approximately 11,000 rupees per month after buying this pump. The consumables, the sensors, the tubings, the changings, it takes 11,000 rupees per month, and the expenditure of this pump is approximately 6 lakh rupees. So it is impossible for each and everyone to consume it. But at least those people who are trying to buy a new car for themselves and they are having MDI, they can buy this pump to keep their car safe. So this is my protocol. Who can afford this therapy should take it at once. Do not prick yourself for 4 times. It is not at all necessary. So it is the responsibility of us as a physician to not keep this financial dilemma in our mind that it is an expensive therapy. Now with this, it is coming soon. Now there are some more things available, might be in March this year, it will be available in our country also. There will be cradle pump. Cradle pump is a pump that is a patch pump. This is a patch pump specifically which doesn't have any tubings. It will be having a cradle and you will not be throwing. At present also these type of pumps are available which are known as Omnipod, but you have to throw the expense of that motor, the reservoir, all is bared by the person who's getting the treatment. So now we have a use and throw system discarded. This is a cradle which will be coming. It will be loaded with a cannula and there will be a permanent reservoir. So the cannula part will be discarded after every 5 days and each and everything can be used. And you do not have to have tubings, those long tubings which are very impossible to carry. So the future is coming more brighter. These type of pumps available, these are going to be launched within March or April. So the science is promoting us to take a leap to move forward. So with these words, patient, diabetes, education and pump training should be implemented with multidisciplinary team under a direction of an experienced insulin pump physician. Now, so how to counsel? This was a paper which we presented in SPAD and it was an oral paper which I presented. It is one of its kind all over world. It was for the first time we did this. The background was there. There has been always a misunderstanding in mind of our patients for insulin pump therapy, even after being persistently advised by us. This is a common thing. Now, pump initiation is in non-government approved setting is always a problem. We look entirely different initiative for pump education and initiation in type 1 people. So for the first time in the history of insulin pump therapy, we have used this method. So the aim was to compare the impact of insulin pump initiation group versus individual installation. 3 hours insulin pump training program was organized for patients to educate them about insulin pump. In this program, type 1 people next to their kin, paramedical staff and diabetic educators were included, and also those people who were using insulin pump therapy were also involved in this group training. So patients included for insulin pump were high level on insulin, who were having glycemic variability, nocturnal hypoglycemia and uncontrolled diabetic, and they were using MDI. So patients were taught about insulin pump, how it is applied, how to take the bolus, how to change the refills, insulin reservoirs. Patients were educated about carb calculation and insulin dose. Within a single program of 2 hours, the things were done. And under one single roof, next to the kin, the pump educator, the people whom we try to educate and who are already using insulin pump therapy, this method was used for the first time. And mind you, a case control study was done. A common questionnaire was designed in these people. Pre and post training sessions were there and these questions were evaluated. The evaluated results, 8 patients were ready to get insulin pump installed. 4 patients were ready to get insulin pump installed. 2, but due to lack of affordability, they postponed the installation. But after this is the slide which I would like each and everyone to consider, and who are listening online, these are some basic questions while giving training, before giving the training for insulin pump therapy, you have to ask from them. So what are these questions? Have you heard about insulin pump therapy? Are you aware of insulin pump controls the sugar levels? Do you know about basal and bolus insulin? How much your low sugar level worries you? Does your sugar level fluctuate? Do you suffer from low sugar level at night without your knowledge? Does insulin injection affect your daily routine? Are you afraid of injection pricks? Is insulin pump a mean of a rich people? Is insulin pump a requirement? Does insulin pump reduce your insulin needs? Are you aware of the cost of insulin pump? Do you feel insulin pump is not for kids? Do you feel that it is difficult to maintain insulin pump? These were some questionnaires in the regional language which I had asked prior giving the training of this pump session. So when I got this answer, and after that we gave a post-training questionnaire to them. What was the workshop useful? Do you consider the use of insulin pump easy? Do you prefer using insulin pump in future? Will the pump save you from a sudden low sugars? Can the insulin pump improve your daily routine? Do you think insulin pump is a means of a rich people? Do you consider insulin pump useful for kids? Do you still think that the maintenance of insulin pump is a problem? And after getting these answers, it was for the first time in the history of insulin pump therapy, we installed 8 pumps at a go. and 4 were ready to get it installed on the next day. So in total, with one training session, we installed 12 pumps. So what it says that, and what did they do? All of them took their, those who were not ready also, they took the mobile numbers, they made the WhatsApp group, and so the group installation group, in which the time for convincing them was only one session. And for those we were individually doing it, it took 4 to 5 sessions. 7 out of 8 were self-motivated. None of them who were doing individually were ever self-motivated. They always thought it is only I am there in the world whom the doctor has prescribed this. And mind you, the education level was not mattering. So in last, with the conclusion, the group installation, the take-home message, whenever you want to educate people for insulin pump therapy, so it is group installation of insulin pump is superior to individual installation. Peer interaction helps in strengthening and learning the process and smoothens the insulin pump management. With this, these are my some last words which I always say. Napo to jano, shakkar se zyada meethi hai zindagi. Life is more sweeter than sugar. Check to know. Thank you.
May I?
Thank you. Thank you very much, Dr. Mishra. Very informative, very futuristic. Thank you for that enlightening talk.
Thank you.
A very passionate and very, very informative talk, Dr. Saurabh. It's always a pleasure to hear you. And you actually do it, so it comes across. I had 2-3 questions. One was, have you been using it in GDM patients? What do you think of that? Second, how old is your youngest patient on a pump? And third is, what about looping? Now, so many youngsters are using that, and how, in your experience, what do you think about looping?
Yeah, it's right. So just I will start from the last question because I will then forget this last question. So looping, do it yourself, DIY, the group, and all those people who are trying to loop it, I will not discourage them. Because once when we as a physician prescribe the insulin pump to our friends, they become very much used to it. They know their glycemic variability, and if we have taught them very properly about carb calculation, about insulin sensitivity factor, they do very much better than what we expect them to do. And so because of that, I will never discourage this type of looping systems because they are doing it very nicely. I have 4 to 5 of my own children who are doing it very nicely. And then the third question, which is the youngest type 1 or a pump user. So she is a 5-year-old. She is in Lucknow, a very beautiful child of ours, and she is happy with it. And the mother is really very much happy. She has now planned to come on to artificial pancreas because it is also governed specifically by AI. So whatever at present she is using Sys40G, which is an automatic pump also. This is sensor augmented pump. And that child, she is just doing all the prep related all her school work, she's dancing, such a beautiful child coming up. Mother is always shy to bring up in public. We wanted that child to be a role model for all the children who are suffering from type 1 diabetes. She's the youngest among all of our people. All over the country, she is only 5 years. But the mother and father, they are very much shy. They don't want to let that disclosure to come out. So I would not like to just take the name of that child. Then coming to specifically GDM. In GDM, as we know, it has to be done for 9 months. The whole all throughout pregnancy, it is 9 months. So might it be it is type 2 with pregnancy, type 1 with pregnancy, or GDM. Insulin pump therapy, insulin pump is nothing as it is just a delivery device. The insulin is the same molecule which has to enter the body. It is the short-acting insulin which is used into it. And we all know until unless it is dissociated into monomer, it will not be used. So just delivering a little amount of insulin, and according to the glycemic variabilities, insulin pump therapy in GDM has been a boon. So what I am doing in my center, we have bought 4 to 5 pumps. The normal pumps, we have bought it and we have kept it on the name of the center, and we give this pump on a rental basis. Specifically, the rent of this pump is 2,500 rupees per month. So all the gynecologists who are knowing that Saurabh and Dr. Rishi Shukla sir is doing this in the Kanpur, they are referring all these ladies to us, and mind you, it has become boon for those people who are affording it. 2,500 rupees is the rent, and approximately the cost is 2,500 rupees another for changing the cannula. And it is very nice. The insulin consumption is approximately 30% less than the conventional dose of MDI, and there are no glycemic variations. You can maintain all throughout the pregnancy the threshold where the fetus will not be alerted 110. So the threshold during pregnancy is never targeted as 120, it is nowadays 110. So it is a dream, and it can be only possible by this insulin pump therapy, because 48 times you can alter the rate of infusion all throughout the 24 hours. Every half hour you can change the infusion rate. So there will be no chance of having any hypers above 150, 110, and you can fit it on CGM basis. Now, with this artificial intelligence, which is artificial pancreas, which is available, the things will be something more. But affordability always will be an issue until unless we are going to have our own pump in our country as Make in India.
Thank you.
Any other questions? Fine.
So now they add,
Yeah.
please. Yes, definitely. Carb countings are the backbone for any type of insulin treatment which we give for our type 1 and also for type 2 people. Type 1 specifically, which I will recommend all my friends who are having type 1 diabetes should learn carb calculation and meal to carb ratio, correction factor, insulin sensitivity factor. It is not very busy. It is very easy to understand. We have limited Indian foods with limited customizations of, you have to learn some few things, and carb calculation and insulin correction has to be done. Might it be it is MDI, might it is pump, both the ways. You have to learn the carb calculation.
Thank you, Dr. Saurav, for a very, very passionate and sharing your experience with everyone. I think it is wonderful learning for all of us. Yeah.
Sir, please, Sanjay sir, Pani sir, please, you also. I will remember this, that I have delivered a lecture in front of my all mentors. Ashna ma'am, please.
Thank you, Chairpersons, for this wonderful session. For the next session of lecture series and the last session of our conference, I invite our Chairperson, Dr. Sanjay Agarwalsa, to chair. Oh, welcome, sir. Dr. Vijay Panikar, sir, as well. Yes, please.
Morning, everybody. I think it's been an excellent morning, and we've had some great lectures. And we come to the last session of the conference. And our next speaker is going to be somebody whom I would love to listen, Dr. Rajiv Chawla. He's done so much of work, building guidelines for the RSSDI. He's going to sort of, not only look at the RSSDI guidelines, but also going to give us a lot of key takeaway points on various international guidelines which have been recently released. There's the ADA, ESD, ACE, NICE guidelines, and look at it from the perspective of the Indian population. Dr. Rajiv Chawla has a great, CV, and I'm sure we can read all that. So I'm not going to repeat it, but Rajiv, welcome to the meeting, and over to you for the lecture.
Good morning, everyone. Thanks, Sanjay. Thanks, Professor Panikar. And thanks for giving this topic, which is so close to my heart. Other day, I was talking about evolving treatment guidelines in type 2 diabetes at Dr. Mohan's, and his comment was like a certificate that, Rajiv, it seems that your guidelines are engraved on your heart, because I said that we have all been part of RSSDI. Fortunately, I had an opportunity to lead that group, but all of us, we were part of those guidelines, which are now very, 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 very practical tool, and we thought that these were possibly guidelines which should be referred to, adhere to, and whenever we are sitting in a chamber, we should always use it as a help. As that cardiologist said, GMDT, that was guideline guided treatment, medical treatment in heart failure. I think it has to be guideline-based management when it comes to type 2 diabetes. So Sanjay asked me to speak on key take-homes or key takeaways on various international guidelines. Do we have a slide changer? Or I do it on? Okay, so I'll start from 2022 because, and toward the end I'll talk about RSSDI guidelines because those are published in 20, and this year, fortunately, with Dr. Sanjay, who is has been one of the most dynamic RSSDI secretary we had in last 50 years, we are again going to have sooner the guidelines, which will be revised guideline 2022, and I'm sure these are going to be published in October or November issue of IJJDC also, and will be released at Chennai annual conference. So let me take you through the ADA guidelines, which are always is sort of gold standard across because although in terms of numbers, RSSDI is one of the largest organization, maybe after ADA. It is one of the largest organization in Asia, but still I think I'll not be biased towards RSSDI guideline, but we have not made an impact globally. So if it comes to guidelines which are followed across the globe, it is the ADA standard of care in diabetes, which every year on 1st of January gets online. So 2022 guideline for the first time talk about criteria for screening for diabetes or pre-diabetes in asymptomatic individuals. And it said that anyone who has a BMI more than 25 and 23 for Asian, because we know we in our own Indian guidelines also we have taken that reference because 23 to 25 is already overweight when it comes to Asian phenotype. So anyone who has a first degree relation with diabetes, who belongs to an ethnicity like African American, Latino, Native American or Pacific Islander, those who have history of CVD or hypertension with HDL levels on the lower side and triglyceride on the higher side, or a woman with polycystic ovarian disease, someone who is not physically active, and other clinical condition associated with insulin resistance. So if you look upon this table, anyone who has more than 25 BMI will have at least one or the other reason for screening for diabetes or pre-diabetes, even if you are asymptomatic. But for all those who don't have a BMI more than 25 when it is Caucasian or more than 23 once it comes to Indian ethnicity, if you are sort of normal, then obviously you should be for the first time screened at the age of 35. But people with HIV or those, I told you, those females, those who had GDM, they should be screened, and even if it is normal, it should be repeated every 3 years. And if that is abnormal or if it is a pre-diabetes detected for the first time, then you need to follow these asymptomatic or pre-diabetic patient once in a year. Once it comes to goals of care, aim is obviously when we are treating type 2 diabetes, we are treating to prevent complication and to optimize quality of life. I really like what Dr. Panikkar said, health span. It is not about only longevity, which we are talking about, that health span. So obviously the aim of treatment in type 2 diabetes is not to get only the glycemic reduction. It is not about the numbers, but actually to prevent complication and optimize quality of life. So their ADA says that you must assess key patient characteristics. Let it be the current lifestyle which you are following, all comorbidities, whether it is presence of atherosclerotic cardiovascular disease, CKD or heart failure, or other things which are very, very important before making a decision on choice of treatment. Then consider these specific factors that impact choice of treatment. So it has to be individualized HbA1c target. I'll be taking this into greater details because we should opt for the drugs which will have some impact on weight and prevent onset of hypoglycemia, and overall side effect of the drug also needs to be considered. So today it is no more a doctrine approach that you tell your patient you take this, I prescribe, this is the best drug, this you must take. No, it has to be a shared decision, making it to create a management plan, sit with the patient. Maybe you may have an educator, half work may be done by an educator. So patient or the family has to agree on management plan. Then you need to implement that management plan, and ongoing monitoring has to be there, of course, with the support system. And towards the end, you may review and agree on a management plan. So after 6 months or 1 year, you realize that in spite of your management plan, you have not succeeded. That is the time you may review your management plan and go on a change. So ADA says that diet, physical activity, and behavioral therapy, an attempt has to be there at least to get more than 5% weight loss. Close to 7 or 10 will be, which will make huge difference in overall outcomes in setting of type 2 diabetes. This slide came as early as 2013. It was a ADA ASD joint consensus for the first time, which talked about this approach to individualization in glycemic targets. They are still adhering to that we need to have a more stringent approach in all those patients, those who are newly diagnosed, where there are not much of comorbidities, where life expectancy is normal or very, very low. There is no established atherosclerotic cardiovascular disease, and if patient can regularly monitor and is very, very highly motivated patient, has good resources, there you should target a very stringent target, something like 6.5. All those patients, those who are on other end of the spectrum, like those who already have comorbidities, established atherosclerotic cardiovascular disease, or their life expectancy is low, obviously they will be not the target for 6.5, maybe 7.25 to 8 may be good enough. But well, the goals will be HbA1c less than 7%, a preprandial capillary plasma glucose which should ideally be 80 to 130, and a postprandial capillary plasma glucose ideally less than 180 milligram. But again, we need to see that whether we are targeting 6.5 or 7 or 7.5, it should not happen on the cost of hypoglycemia, which they have very, very clearly classified. Level 1 hypoglycemia, once your sugar is less than 70 milligram. Level 2 is when your sugar is already dipping as low as 54 milligram. And level 3 is what is classically labeled as severe hypoglycemia, where you need a medical assistance to come out of that. For the first time, 21 also, and in 22 guideline, they have incorporated and highlighted the importance of getting glycemic targets, reducing those glycemic variations, so that glycemic variability has to be cut down. For that, ADA today says that we must rely on continuous glucose monitoring, maybe with the help of sensors or AGPs, what Dr. Saurabh was just talking about. An attempt has to be there that most of your patient, for 70% of time, they should be in time in range, what is 70 to 180 milligram. Less than 25% time, it should be more than 180 to 250, and less than 5%, it should be more than 250. That means total time above range should not be more than 25%. And hypoglycemia idea is very, very particular on that it should not happen. It should not be for more than 5%. Severe hypoglycemia, which I just said, grade 3 hypoglycemia or severe hypoglycemia should be for less than 1%. So obviously that cannot be targeted. All these targets cannot be met until unless we are doing a continuous glucose monitoring, or maybe an AGP or other devices are being used. So when it comes to the pharmacological treatment of hypoglycemia in adults with type 2 diabetes, again, keeping in mind that patient-centric circle, ADA says that first-line therapy obviously will depend on the comorbidities. So it has to be a patient-centered treatment, factors including cost. For the first time, they have talked about cost. Will in our guideline, when I'll be talking about that, we have kept a separate provision that all those patients, those who cannot afford expensive therapy, their choices have to be different. But ADA also now is talking about cost factor and access to the treatment, because there also you have many patients, those who are not covered under the medical insurance. So if there is a presence of atherosclerotic cardiovascular disease, or the risk is very, very high with multiple risk factor, patient has incipient or manifest heart failure, or presence of diabetic nephropathy or CKD, their clear options are either going on a GLP-1 receptor agonist with proven CVD benefits, or an SGLT2 with proven CVD benefits. So irrespective of your glycemic goal, we are not talking about getting a glycemic reduction here. We are saying that every patient who has presence of atherosclerotic cardiovascular disease, heart failure, or diabetic nephropathy must be on GLP-1 receptor agonist or SGLT2 inhibitors. If it is presence of heart failure, manifest or non-manifest, then obviously the first option is SGLT2 inhibitor, because it scores over even GLP-1 receptor agonist, not only in terms of reduction of hospitalization with heart failure, but also composite CVD and heart failure. The overall figures are much better, almost down by 20%. If it is about CKD, when it comes to presence of albuminuria, their GLP-1 receptor agonists are also very, very good. And SGLT2 inhibitors, they are proven to have reduction in renal composite endpoints by at least 35 to 40%. If patient is not having all these risk factor or presence of heart failure or CKD, then obviously what you're looking for is getting a very, very efficacious reduction in HbA1c, so as to at least reduce onset or propagation of microvascular complication. There again, attempt has to be, great emphasis is on reduction of hypoglycemia. So drug option has to be something like DPP4, again GLP-1 receptor agonist, or SGLT2 or TZs are wonderful drug. I know Dr. Panikar, he is a greatest advocate about usage of TZs, pioglitazone in this country. So their AD also said that maybe TZs, which is a very good option in these patients. And an attempt has to be, again, to minimize weight gain, to promote weight loss ideally, more than 5% or 7%. Obviously, their option will be something like GLP-1 receptor agonist or SGLT2. But AD again here says that if it is the cost which is important, because every patient may not be able to afford what to talk about GLP-1 receptor agonist, there even SGLT2 inhibitors are $18 one tablet. So all those who are not covered there may not be able to use even SGLT2 inhibitors. So they may be a good candidate for even starting on sulfonylurea or TZs also. And they have again tried to stratify or make this pharmacological option based on their profile, whether they reduce weight, whether they reduce chance of getting hypoglycemia, how good they are in terms of getting efficacy. And you could see that metformin, Professor Panikar was talking about that TAME trial, that metformin is a wonderful drug, not only in terms of getting good glycemic reduction, but other benefits are also there. Once it comes to SGLT2 inhibitor, we know that not only they are getting a modest amount of glycemic reduction, but for extra glycemic reduction, these are the best drugs. And of course, GLP-1 receptor agonists are the best drugs in terms of getting the highest amount of HbA1c reduction after insulin without inducing any hypoglycemia. So all these drugs need to be viewed in that light. Once it comes to new onset diabetes in youth patient, those who are overweight or obesity with clinical suspicion of having type 2 diabetes, this category has been put for the first time in the protocol or in the algorithm, that all those young onset diabetes, if they are obese or they are overweight, and there is a clinical suspicion that these patients are type 2, because at hyperglycemia onset, you may not be able to do even C-peptide levels to differentiate. So if patient is having clearly symptoms of acidosis or decay, obviously they are the candidates for insulin therapy. But if patients have HbA1c less than 8.5, there's no acidosis, no ketosis, obviously you must start with metformin. So AD also today says that you must start with metformin. You may go as high as almost 2 grams per day. Still targets are not met within 3 months, then you can choose other drugs. But all those patients, those who have HbA1c more than 8.5, no acidosis with or without ketosis, they again must be started on metformin, go up to up titration of 2 grams if required to fix their fasting sugar. then a basal insulin could be the best option. So today, once it comes to cardiovascular disease and risk management, when we are talking about 3-point MACE reduction, it is not only glycemic control which is important. After lifestyle modification and diabetes education, which remains the hallmark of any therapy, after glycemic management, it is a blood pressure control, which is very, very important. Equally important is lipid management in this patient with statin or with other drugs. And again, most important thing to reduce that cardiovascular risk is being on drugs like SGLT2 inhibitors or GLP-1 receptor agonists. So all those patients in ADA, in summary, said that considering treatment goals for glycemia, blood pressure, and dyslipidemia in older adults, I told you those patients, those who are young onset diabetes, here it is talking about elderly patients. So it says that if this patient is healthy, even if age is something like 65, but there is a longer remaining life expectancy, patient doesn't have too much comorbidities, again it will be reasonable targeting even less than 7 or close to 7. But those who have already complex intermediate scenario, couple of comorbidities are already there, or there is a cognitive decline, obviously you should target something like 8. Their fasting could be anything 90 to 150, though they are not talking about 80 to 130, what is typically asked for. And obviously bedtime sugar could be even as high as 100 to 180, but blood pressure control again here needs to be highlighted. It has to be less than 140/90, and statins will be a good promising drug. But all those patients, those who have too much complexities, they are on other end, what I told you in ADA ASD 2012 guidelines also, at the other end of the disease with too many comorbidities or end stage diseases or already having cognitive decline, there you may not have any glycemic target, something like 8 or 8.5. Must attempt reducing the symptoms of hyperglycemia, and you must not induce hypoglycemia. That is a very, very strong message by ADA. Let their fasting be between 100 to 180, and baseline bedtime sugars even as high as up to 200 milligram, but must get down their blood pressure again less than 150/90, and here also statin could be useful drug. And for the first time, ADA has also incorporated this KDIGO document, which has come in 2020, that to reduce the risk of chronic kidney disease progression, the frequency of visits and referral to nephrologists according to glomerular filtration rate and albuminuria. So in this grid, on one hand you have A1, A2, A3, what is albuminuria. On other hand, you have normal EGFR, and then it is going to come down, and based on that, wheresoever your patient is resting, you can see how poorer is going to be the prognosis, and earlier these patients should be referred to a nephrologist. So coming to ACE guidelines, this is actually a 2020 guideline, and certain upgradation has been done. The principle of this ACE document are lifestyle modification. It underlies all therapies as has been sent by ADA. Again, as ADA said, we must avoid hypoglycemia, avoid weight gain, individualize all glycemic targets, whether it is HbA1c, fasting or postprandial control. Optimal is obviously getting an HbA1c less than 6.5, as close to 6.5 as possible without inducing hypoglycemia. That is very, very important. So choices has been, again, in the same way that you should choose drugs which could say address issue of atherosclerotic cardiovascular disease, heart failure or renal status. Comorbidities, again as said by ADA, must be identified and eluded or addressed to get to goal as soon as possible. You may not wait for 3 months, what is typically said. You may intervene even in 3 weeks time or 6 weeks time, until unless patient is at goal. Choice of therapy includes ease of use and affordability. And again, like ADA 22 said, CGM is highly recommended, because that could be the only way if you are targeting something like 6.5 or 7 without inducing hypoglycemia. Great emphasis has been again on nutrition and intensity stratified by burden of obesity and related comorbid situations or complication.
that you maintain an optimum weight, calorie restriction has to be followed, a physical activity of at least 150 minutes has to be followed, and you must have a good quality of sleep, which has not been talked in ADA or even in our own document. So we must have 6 to 8 hours sleep so as to get a normal biorhythm, because then your counter-regulatory hormones are on the lower side, your blood pressure will come down, and you will have a much better glycemic control also. A behavioral support has to be there, and most important is that smoking cessation has to be there. So in this ACE document, they have divided into different models. The first slide talks about complication, which is a centric model for care of the patient with overweight or obese patient. So for the first time, they have defined adiposity-based chronic disease management. So it said that in the first step, you look for the BMI of the patient. If BMI is less than 25 and it is no overweight, because these are Caucasian patients, but if your BMI is already more than 25 or even 27, most important thing is to look for presence of cardiometabolic diseases or comorbidities and the impact of obesity, like biomechanical complication which could happen in the setting of type 2 diabetes. And based on that, you need to choose the therapeutic agents for improvement in complication. You must simultaneously treat these issues of obesity, and it has to be, of course, first thing has to be the lifestyle modification that has to continue. But again, a great emphasis is on medical therapy to reduce weight, which could be in different ways, either drugs like phentermine, topiramate combinations, or naltrexone combination, or lorcaserin. Unfortunately, these drugs are not approved in our country. Liraglutide also, we have been using off-label. 3 milligram was not available, but in US, all these drugs are already available. So a great emphasis has been even to have a medical therapy to induce weight reduction. If BMI is very, very high, something like more than 35, is surgical therapy in the form of an endoscopic procedure or a gastric mending, or could be a sleeve or bypass surgery. In pre-diabetes algorithm by ACE, again it talks about lifestyle modification, and it again says that you must treat atherosclerotic cardiovascular disease risk factor, even if there is not too much of hyperglycemia to label it as type 2 diabetes. But again, you must treat or address to atherosclerotic cardiovascular risk factors by statins, and try to correct that dyslipidemia, patient hypertension, try to correct that also. And every effort has to be there so that these pre-diabetes patients don't get converted into type 2 diabetes. We know in India we have close to 75 million diabetics and an equal number of pre-diabetes patients. So every effort has to be there by having at least a lifestyle modification, not drugs, but certain drugs like metformin, acarbose could be used from based on overall profile of the patient. TZ, we know, although it increases weight, but this has been a wonderful drug once it comes to reduction in insulin resistance also. So in terms of reduction of atherosclerotic cardiovascular disease, I told you dyslipidemia management has to be there, starting with lifestyle modification, and then based on the levels, we need to again quantify that risk, stratify that risk. How bad is that risk in that particular individual? If risk is very, very high, you have to go on very high doses of statin. So it says that LDL targets are based on the risk which is present. If it is high risk, LDL has to be less than 100. If it is very high, it has to be less than 70. All those patients, those who have extreme high risk of CVD, their LDL ideally should be less than 55. So same way, they have also identified the targets. So TGs and ApoB also, which need to be addressed. Once it comes to management of hypertension in these patients, ACE and ARB for every type 2 diabetes patient, or even at a stage of pre-diabetes. But for better hypertension reduction or blood pressure reduction, you may go on calcium channel blocker. These days you have second, third generation calcium channel blockers, maybe beta blocker, or even thiazide group of safer thiazide groups of diuretics also. So finally, ACE, when it talks of glycemic control, it clearly individualizes the goals of getting HbA1c, not 7, what has been said by ADA. It talks about 6.5 for all those patients where there are not much concurrent chronic illnesses or comorbidities, and where you can get HbA1c less than 6.5 without inducing hypoglycemia, that is very, very important. But all those patients, those who already have comorbidities, obviously target will be something like 7 or 7.5. You need to start with lifestyle modification. But one most important thing which is there in any algorithm in Indian international guideline is independent of glycemic control, if you have presence of atherosclerotic cardiovascular disease or multiple risk factor, CKD, or diabetic nephropathy or heart failure, these patients must be on GLP-1 receptor agonist or SGLT2, irrespective of the glycemic control. Even if patient is already having 6.8, better reduce other drugs. Maybe even you may reduce metformin, but make a space for usage of GLP-1 receptor agonist or SGLT2 inhibitors so as to reduce overall cardiovascular risk in these patients. So ACE only talks about entry-level HbA1c. If it is less than 7.5, you may, in typical patient, garden variety of patient, you may start with metformin, but all those who have multiple risk factor, you must start with GLP-1 receptor agonist or SGLT2 inhibitors. If entry level HbA1c is 7.5 to 9, you can have dual therapy, which must include other than metformin, ideally a GLP-1 receptor agonist and SGLT2 inhibitor. But if entry level HbA1c is more than 9%, and patient is too much symptomatic, that is the time where you may start with basal insulin and then intensify it to, this is how you start with a basal insulin. If HbA1c is less than 8%, you give only 0.1 to 0.2 units per kg. If it is already more than 8%, you may start with 0.2 to 0.3 units. And these are the algorithms to down titrate or up titrate the doses. But if still targets are not met, in spite of getting a good fasting control with basal insulin, that is the time you must add prendial, which could be basal plus 1, basal plus 2, basal plus 3, or it could be a physiological basal bolus therapy. Again, like ADA, even ACE has given the profile of anti-hyperglycemic medication. It is too busy a slide. I'll not be going into the detail, but again, suffice to say that many patients may do well with metformin, but most of the patients, those who have these complexities, presence of atherosclerotic cardiovascular disease, or maybe diabetic nephropathy or heart failure, better be on SGLT2 inhibitors or maybe drugs like GLP-1 receptor agonist. But DPP-4, it said, are classically neutral on all the outcomes, but they are very good in terms of getting good glycemic control. For the first time, ACE has included diabetes management in NAFLD in the guideline, and it advocates that fibrosis risk stratification has to be done. If it is low, intermediate, or high, based on that, we must optimize glycemic control. Again, it talks about that we must use either GLP-1 receptor agonist or SGLT2. And again, what Dr. Panikkar will say, that every patient, those who are even at a low risk or intermediate risk for developing NAFLD and subsequently NASH, they must be on pioglitazone, because even in that PVN trial, we have seen that it was pioglitazone where almost ballooning or steatohepatitis was reversed in the group which has type 2 diabetes. Now, coming to RSSD ASI therapeutic wheel, I told you it is very close to my heart. We are shortly revising this with a new wheel which will be getting published in 2022, this year only. This is ABCDEFGH approach. This is for the first time any guideline has talked about all these spokes, and I'm happy to share in this small gathering. We had a lot of mentors like Dr. Panikkar, Shashank was there, and it was a joint consensus with Endocrine Society of India. Dr. Jacob is here, Professor Madhu was one of the conveners for this. But this wheel, for the first time in 2015, was conceived by me, and it was drawn by one of my DNB students, Dr. Ashwin. We sat on this wheel along with Bansi and Madhu on the airport for 3 to 4 hours in a very hot summer, because Bansi was traveling to some ESD or some conference, and we could get 3 to 4 hours sitting on the airport outside, not inside. And we alluded to this, that how to put all the spokes in this wheel. So A is advancing age, B is BMI, increasing BMI, C is presence of CKD. This was very tricky when we talk about lifestyle modification in the center, and in Indian guidelines, we talk about usage of metformin for every patient until unless there are contraindication. So how to put this C in this? So we cut metformin here. You could see that that blue graph, that blue circle is cut here because if there is an advancing CKD, we may not be able to continue metformin till long. D is the duration of diabetes. E is established atherosclerotic cardiovascular disease, what AD and ACE are talking about. F is the financial status. We were very, very sensitive to Indian patient. Not many patients, those times, even generic SGLT2s were not available, will be able to afford GLP-1 receptor agonist or SGLT2 inhibitor. H is proneness to hypoglycemia, and G is the glycemic status. In the center is lifestyle modification, then metformin for every patient, and then you have green circle, which says that all drugs, all anti-diabetic drugs could be used safely. Here you may something like, even while sitting in this conference, you may prescribe on WhatsApp because all drugs in this zone are safe. But mind it, as we are moving from the center towards the periphery, you have an orange zone and a red zone because towards the red zone, options are getting very, very narrowed. The hierarchy of therapy is depicted in a clockwise manner. I don't have time on this. I made a presentation 45 minutes alone on this wheel because every drug here is based on evidence. It is not just that we have put sub SGLT2. You could see that in BMI, the first option is SGLT2 inhibitor or GLP-1 receptor agonist. But as your BMI is even going higher, so SGLT2 and GLP-1 receptors are getting even a higher hierarchy. Same way you could see the presence of CKD. If CKD is advancing, last option in the red circle are only DPP-4, which have a dual route of excretion, and maybe insulin. Similarly, in the F column, you could see that financial constraint is there. The best option may be a conventional sulfonylurea or a conventional insulin or pioglitazone, fortunately, which is very, very reasonably priced in this. So how to use this wheel? This wheel is designed to be a very simple, user-friendly approach to decide the appropriate anti-diabetic agent to be used in type 2 diabetes. Whenever you see a patient in your clinic, try to identify 2 to 3 important concerns. Out of that, out of A, B, C, D, F, G, H, try to pick up what is important. In certain patient, it may be presence of CKD. In certain patient, it may be a financial constraint or age, and based on that, you get the best option. NICE guideline 2022, again, is very, very conventional, very, very conservative guideline. We know because there it is an NHS system. They are still banking on sulfonylurea and metformin and maybe insulin. Even still now in their algorithm, we don't find a place of using GLP-1 receptor agonist. You could see at the bottom only, if there are no options left, ideally you should start with metformin in every patient. If patient is not tolerating, you may just give a modified release metformin. You could choose drugs like DPP-4, Pio or sulfonylurea, which are very, very reasonably priced, but you could also choose SGLT2 inhibitor depending on the presence of ASCVD or other things. And if the risk is very, very high, again, it says start with metformin, add SGLT2 inhibitor. But at the bottom only, it says that if patient cannot tolerate SGLT2 inhibitor, benefits are still not enough. That is the time you may refer it to an endocrinologist. Get an approval for starting a GLP-1 receptor agonist. This is where it is. In the last, you could see the GLP at the bottom. So it conventionally still talks of using metformin, DPP-4, pioglitazone, and sulfonylurea. Maybe you may add SGLT2, not in every patient. In our algorithm, we are talking of SGLT2 inhibitor as a first-line option. It says, forget about glycemic control. Every patient must be on SGLT2 inhibitor or GLP-1 receptor agonist if there is a complex situation. But still, NICE guidelines being very, very conservative because of financial constraint says that GLP could be the last option where you cannot use insulin. After SGLT2, you still don't have good glycemic control. You're not being able to address other things. You may still choose a insulin, but certain patient may not be the right candidate, like those who are driving, those who are pilots, may not be the right candidate for very high dose insulin. There you need to have a permission for choosing GLP-1 receptor agonist. Towards the end, ADA, ASD, well, these guidelines are getting upgraded. Still, this is the current information till last night that they've already made the protocol, the practical tips for implementation of ADA, ESD joint consensus are out, but this has to come somewhere. I think, I'm sure this may get published in ESD in this September. But before I close, I think, although KDIGO guidelines was not part of my presentation, but I thought it is very, very important because there has been a great emphasis not only on lifestyle and first-line drugs like metformin, SGLT2, RAS blockers. Finerenone is about to get launched. Statins must be there. So new MRAs, GLP-1 receptor agonist, antiplatelet drugs, and lipid management is going to be crux, even in those patients where we are targeting goal-directed or mediated therapy. So this KDIGO guideline talk about lifestyle modification in the beginning. Start with metformin as a first-line option. Continue till EGFR 30. Don't add a new patient after 45. But if it is a situation of dialysis, you must stop metformin. Again, SGLT2 inhibitor based on current data from EMPA heart failure and DEPA heart failure and DEPA CKD. Now they are talking about that SGLT2 you could use till EGFR 20, but don't initiate if EGFR is already very low. But if patient is going for dialysis, there you need to stop that. You could continue GLP-1 receptor agonists, which are preferred drugs, DAPP4 inhibitors, till end-stage renal disease, even in dialysis patient. Insulin is possibly the gold standard for those patients. Short-acting sulfonylurea or non-sulfonylurea secretocoque or even AGIs could be good option if EGFR is already less than 30. Thank you very much for your patience listening, and I'll be very happy if you have any questions to ask. I'm sorry I exceeded by 5 minutes, but I thought that I must do justice to this topic.
Rajiv, as usual, you are the boss. The RSSDI guidelines, he was the leader who set the tone. We were all supporting actors. Yes, with each. But his vision and his conceptualization of the whole thing has been excellent. And I think next week we are again meeting in Delhi for the new guidelines which will be coming.
14th of August we are meeting
14th of August. So
you should be happy that you rightly mentored your junior brothers. Thanks a lot.
Sir, you are great. Thank you.
etc.
AGIs already exist in our guidelines, but this time in our revised edition, we are going to give AGIs written higher based on Indian. Unfortunately, ADAs don't talk about AGIs because there is no evidence. These are not yet approved other than the Agarwalsa. Entire evidence is from Indian ethnicity, but I don't have time but to quote that Indian patient, even at an HbA1c of 10, they have not only high fasting blood postprandial, even at HbA1c of 7, which is classically postprandial, there also we have 50 to 60% postprandial composition. Because of high carbohydrate intake, we are the right, Asian patients are the best patients to be on AGIs. So if we all agree, we will give a higher hierarchy for AGIs in current guidelines.
And drugs like saroglitazar and chloroquine.
Saroglitazar is still not approved in management of type 2 diabetes. For hypertriglyceridemia and type 2 diabetes is already approved. NAFLD data is shortly coming. Type 2 with NAFLD may be the best option of the saroglitazar. Yeah, thank you.
So I'm very glad to call the next speaker, Dr. Jugal Jacob, sir.
So I think we had a very masterful lecture on all the various guidelines and how to manage type 2 diabetes. So the take-home message is type 2 diabetes is very complicated. If you look at the ADA goals of therapy, you realize that there are 7, 8 goals you have to look at. And when you see a patient with diabetes in front of you, you looked at the ACE guidelines. They have now included liver protection as one of the things that you should be doing. And when you look at all these guidelines, you look at the wheel, You have to look at so many things before you decide on drugs. So I'm going to talk a slightly different thing. I'm going to talk about whether we can, do all this with a single combination of two drugs, an SGLT2 inhibitor, DPP4. Fortunately, Dr. Chawla, because now we have generic combinations of DPP4 and SGLT, the financial issues is also taken care of. And when you have a patient in our OPD, we cannot look at all these 8 goals, because it becomes very difficult. So what I do is I've taken this from what we learn in community medicine, the Maslow's hierarchy of needs. So when you have a patient in front of you, you cannot have all these goals together, but you have a hierarchy. You do one thing at a time, and in about 3 to 4 visits, you may be able to get things under control. So this is what my pyramid looks like, the hierarchy of needs in metabolic control. Obviously, the first thing to start with is symptom control, and what the patient's felt need was. If the patient came with an infection, you need to treat the infection. If the patient came with hyperosmolar symptoms, you need to treat that. The second thing, the patient comes to you as a diabetologist or an endocrinologist, he's to some extent focused on glucose control. If he's not seeing those changes in numbers, he's going to get unhappy with you. The second part of my pyramid is what I call glucose control. The third part is what is called the icing on the cake. And this is what I think most of us are focusing on, but we have to focus on the pyramid, base of the pyramid before we go on to what we call the icing on the cake. The icing on the cake is something that we have done now for almost 10, 20 years since UKPDS came. We realized that we could reduce microvascular complications by achieving a certain target. 7 is what ADA believes, 6.5 is what ACE believes. But these are all based on vasculometabolic health, microvascular outcomes. Some macrovascular outcomes, but primarily if it was early stage diabetes, less than 10 years, you could do good in terms of macrovascular outcomes as well. Now I think you've seen the ACE guidelines, it's an obesity-based guideline as well. So we have what we call chronic control, obesity-based outcome, what we call barometabolic outcomes. We want to improve weight. Previously our main goal was avoid weight gain. Now our goal is not just avoid weight gain, we want to see 5% weight reduction. If you want to see diabetes remission, you need at least 15% weight reduction. So that is another part of the hierarchy. After vasculometabolic health, you need to ask yourself, can you get better barometabolic health? And on top of the pyramid is what I call viscerometabolic health. That includes improvement in liver steatosis, improvement in obstructive sleep apnea, gonadal health. We have women who want to get better reproductive health. We have men who want to get better testosterone levels, which can be achieved with weight reduction, with glucose control. I think that is the tip of what I call the icing of the cake. And if we can do all this as a pyramid and with a single drug, it's a great idea. And it becomes very easy for me because I do not have to then refer to the wheel and decide which are the things that I want to do. So this is what I'm going to talk about. And in vasculometabolic health, I'm talking about 3 things. We always talked about microvascular health. We talked about macrovascular health. And now, of late, we are also talking about heart failure protection. And all these 3 together, you could call as cardio-renal metabolic syndrome or CARI-ME syndrome. And we realize that some of these are very interrelated. That means the heart and the kidney are very interrelated with hyperglycemia, with insulin resistance, with oxidative and neurohormonal reflexes, with fluid overload. So there is significant interrelationship between all these complications. And you realize that almost all these complications have a 2 to 4-fold increased risk in diabetes, whether it is cardiovascular disease, whether it is stroke risk, or whether it is heart failure risk. It's almost 2 to 5-fold more in patients with type 2 diabetes. But here we suddenly start thinking every one of these complications should be given the same kind of attention. Probably not. The reason why I think heart failure is king among all this is if you look at the first presentation of cardiac problems in patients, this is a large cohort of about 1.9 million. So commonest presentation was not an MI or a CVA, it was actually hospitalization for heart failure, for cardiovascular disease. So I think the FDA for many years has concentrated on MACE outcomes, on heart failure, on CVA, non-fatal MI, and cardiac death. But we now realize that heart failure is much more commoner as a presentation, and this is one reason why heart failure is king. The second reason why heart failure is king is if you look at mortality data. We have done very well with MI. We have statins, we have stents, we have antiplatelet agents, lots of antiplatelet agents. You can see the blue lines in this are the blue lines here are what the MI death rates are. Look at what the heart failure death rate is right on the top there, along with peripheral vascular disease. Again, this is one area where we have not done very well. This is about 1.5 lakh patients. So this is the reason when I think about that base, the vasculometabolic health, I think heart failure is king, much more than strokes and myocardial infarctions. And this is heart failure development. At any year, you can see the highest 5-year absolute and relative risk of death. Now, renal disease is also there. Just below heart failure, just below peripheral artery disease is renal failure. And you know that renal disease in people with diabetes is very common. 40% of them will develop, and diabetes is the leading cause. And now we know the interactions between kidney and when you have heart failure, the body tries to protect the heart by measures which is going to damage the kidney. When you have kidney failure, the body tries to protect the body from kidney failure and it is the byproduct of that, it might damage the heart. So it is a bad loop. And that is why I think Dr. Chawla already showed us these guidelines. All these guidelines are now completely focused on vasculometabolic health, that is heart failure, renal failure, and cardiovascular disease. You can see the primary part of all the treatment guidelines in diabetes, whether it is ADA, it is focused on heart failure, heart disease, and renal disease. Whether it is ACE, it's also focused the same way. You have glucose control, which is metabolic control, but additionally you have heart failure and renal disease, which are concentrated here in the middle part of the guideline. Whether it is the ESC, EASD guideline, again, primarily focusing on heart failure, renal disease, and atherosclerotic cardiovascular disease. So now the question is, it's a big pyramid, and we have so many things on the pyramid. Can we achieve all this with a simple combination of an SGLT2 DPP4 inhibitor? Whether this is the key. If we consider that glucose control is the key, I think this is a drug with extremely good glucose control. I think one of the reasons is that it is going to work on multiple pathophysiologies which underlie any patient with type 2 diabetes. It also has complementary effect. You know that when you lose glucose in your urine, you are going to have a hyperglucogonemia. That is the response of the body when you lose calories. And you know that DPP4 inhibitors have direct action on alpha cells to reduce that hyperglucogonemia. So it has complementary actions. It also has significant efficacy versus using those drugs individually. This is a large meta-analysis looking at the combination of SGLT2. Now you remember, these are various combinations. There are patented combinations available. There are generic combinations currently available. And this is a study of all the trials. And you can see HbA1c difference between using a combination of SGLT2 DPP4 versus just DPP4 alone is about 0.62%, remembering that these are all patients with a baseline HbA1c of about 8%. So it is significant here, 0.6%. When you look at this efficacy in different patients, somebody starting with 9%, somebody starting with 10%, you can see the efficacy is going to be higher. So somebody who's starting HbA1c is 9.5%, is going to get 1.5, 1.6% decrease in HbA1c with this combination compared to using DPP4 alone. Now looking at the other side, the combination versus just plain SGLT2 inhibitors, again, I think it is very clear that you get much better glucose control with the combination. This is where the baseline HbA1c is about 8, and when the baseline HbA1c is higher, you get better glucose control. So I think the first two part of the pyramid, that is symptom control and glucose control, I think the choice of SGLT2 DPP4 inhibitor becomes a very potent and effective choice. Now, the slightly on the top part or the icing on the cake was beta metabolic control. I think SGLT2 here is going to provide you some degree of weight loss, may not be the extent that you would get with a GLP-1 analog, but still significant weight loss. We are talking in terms of 3 to 4 kgs weight loss, and these studies where they've compared SGLT2 versus DPP4, you can see there is about a 3.4 kilo weight loss that you see with this combination. In terms of safety, both these drugs potentially do not cause hypoglycemia, so we do not have issues with hypoglycemia. But what is surprising initially when I first saw the data was when we used this combination, some of the side effects of SGLT2 inhibitors also were reduced. And primarily the side effect of SGLT2 which were reduced was the occurrence of genitourinary infections, the candidal genitourinary infections decrease. And this is not just with one combination, almost it has been now seen with all the 3 combinations that are currently available. Now, today my job is to, this is a promotional talk, my job is to introduce this generic combination of dapagliflozin and sitagliptin and tell you that whether this is the answer to this pyramid, rather than take a lot of time in choosing the drug, whether this, even in patients who cannot afford, I think this combination will become very affordable because I'm sure there are many, many companies which are going to bring out this combination of dapagliflozin and sitagliptin as a generic pill. Now, we don't have any data of this pill together, but we do have data where this is a clinical trial which looked at patients who were on placebo versus sitagliptin. So these were patients baseline on sitagliptin who were then added dapagliflozin versus placebo. This was for looking at the efficacy of dapagliflozin. It was not to look at sitagliptin here. But what is clear is the combination at 24 weeks, there was a difference of HbA1c by about 0.5%. And at the end of 48 weeks, 48 weeks, there was a difference of 0.7%. So not just the efficacy that is initially, but there is also an efficacy which is sustained. And in fact, it gets better as time progresses. So that is one good thing with this combination of dapagliflozin and sitagliptin. The other things, the beta metabolic control that we looked at, you can see the body weight reduction is about 2 kilos in this group who are using both sitagliptin and dapagliflozin. The fasting blood sugar control already you can see about 24, and also a slight reduction in systolic blood pressure in patients. Now, I think this is a guideline, not really a guideline. This is an expert opinion published in Diabetes Therapy. A lot of leading endocrinologists and diabetologists were here. So now to make things easier, now this is an expert opinion, not the RSSTI guideline, not the ADA EASD guideline. So their expert opinion was, if you have a new patient with type 2 diabetes, initiate with lifestyle modification, start on metformin, monotherapy, if the HbA1c is less than 8%, but if the HbA1c is more than 8%, you know just metformin monotherapy may not be enough, and there may be a choice of using or a possibility of using this combination along with metformin. Again, if metformin is for some reason not tolerated or contraindicated, again, this could be the first choice, a combination of dapagliflozin or sitagliptin. They didn't use this particular combination. They said any of the SGLT2 DPP4 combination could be used. So this is as an initial management. Similar thing as management as a second line on patients who are already on metformin or those who are already on insulin and other agents. This, if they are still not meeting the glycemic target, this could be a good combination to use in them as well. Now, for promoting weight loss, preventing hypoglycemia, both HbA1c criteria, you could use SGLT2 inhibitors, you could use DPP4, but you could use a combination as well. Based on CV risk, you know that dapagliflozin is going to give you heart failure protection, is going to give you renal protection, to some extent is going to give you atherosclerotic cardiovascular risk reduction also. So I think this combination will work, and we know sitagliptin With some gliptins, we have some worries about heart failure. With saxagliptin, we have these worries. But with linagliptin, sitagliptin, we do not have that worry. So this combination is extremely well suited in patients with CV risk, especially if they have heart failure. Again, extremely well suited because dapagliflozin is one of the most well-studied drugs in patients with renal failure. So that is the reason why this combination is well suited. And we know from sitagliptin studies, though it may not preserve EGFR, it does have some studies in terms of reduction of albuminuria and preserving EGFR. So I think summarizing, we heard masterful talks on all the various things we need to do. But if you are short of time and if you're following a pyramid and you want to decide things quickly, I think if you look at this pyramid in terms of both metabolic control, in both terms of glucose control that the patient can see in terms of improvements in his values, and the icing of the cake, which is vasculometabolic control, barometabolic control, and now what we talk about is viscerometabolic control, improving liver outcomes, improving gonadal outcomes. I think this combination may be an excellent choice, and I'll stop here, and I'm very happy that I was invited here. Thank you very much.
Are there any questions from the audience? Sir.
In combination with?
At that time, insulin. Now,
yes.
You are advising it, so you reduce the dose because we know that in some maximal dose, you get maximal efficiency.
Yes. So I'm talking about early use with metformin and the combination. I do not think we should be getting any significant hypoglycemia. Yeah.
How can you predict? What do you be more cautious?
No, sir, by and large, sir, by and large, when you talk of hypoglycemia, there are only two molecules which will significantly cause hypoglycemia: insulin and sulfonylurea. The others, the incidence of hypoglycemia is negligible. That's why I said.
I think
no, that's why I said negligible. No,
I think
if
we are now going into areas where we did not discuss. Even.
It can cause hypoglycemia.
No.
So whatever is it, those may be in combination, you give not the full dose.
So even if you do randomized control trial, there will be hypoglycemia in the placebo arm as well.
Correct.
So those are probably not related to drug. Those are reactive hypoglycemia we see as part of type 2 diabetes. We cannot, because we know the mechanism of action of drugs should not cause hypoglycemia.
We don't know how it causes foodious gangrene. Your DP4, your SGLT, nobody knows.
Yes.
So what has to be? Extra cautious.
I think every new drug you have to be cautious, but I think now we have had experience of almost 20 years with DPP4, 10 years with SGLT2. We are. All right.
Thank you.
Thank you,
Thank you
sir.
so much. Thank you.
Thank you, sir. Excellent
Thank you.
presentation.
Thank you.
Yes.
The next, शशांक, come. क्यों छुप के क्यों बैठा है? Joshi, are triglyceride level responsible for residual cardiovascular risk? A lot of talk has been going on triglyceride and the residual cardiovascular risk. Shashank doesn't need any introduction. He is my colleague in, I should say my partner. or my younger brother in Lilavati Hospital. We have a joint practice, and he practices more than me because look at him, he's slim and trim. So he practices what he preaches. I do more consultation. Shashank, over to you.
Vijay, thanks so much for waiting, and thank Sanjay, Neeta, and the entire team of IDEC. They gave me a topic which is I'm the last batsman in Hall B. I'm happy that you stayed over so that we can travel back together, and I'm sure you have taken the rounds today. So, the topic which Neeta allocated to me was are triglyceride levels responsible for residual cardiovascular risk? And that topic actually has gone through a lot of transformation. And my link with obesity, adiposity, remnant cholesterol, assessment of type 2 diabetes is very different. And that's something which we all recognize. So I think I'm going to talk of that topic very little. And I'm going to talk of adiposity in the cardiovascular conundrum. Then treat LDL cholesterol or remnant cholesterol. That's where actually triglycerides find their place. Then stratifying cardiovascular risk. That's where we are moving. And there's a lot of new perspectives which probably Sanjay and Neeta wanted me to discuss on non-HDL cholesterol, remnant target levels, and then finally some data which is emerging on triglycerides on the residual risk forefront. But the first part is DBCD, and I can see Urmo is here, right here. Our good friend Jeffrey Mechanic always talks about this DBCD and adiposity and defining the cardiovascular risk, and it's all about dysglycemia-based chronic disease now. In stage 1, it's molecular at insulin resistance. Stage 2 is biochemical and cardiometabolic at pre-diabetes. Stage 3 is all about biochemical diabetes. Stage 4 is all about complications, which are vascular, 4A, 4B, 4.3. And it's all complex interactions of genome, epigenome, environment. And clearly we know that we need a population-based approach to strike these mechanistic drivers. There's a lot of mitochondrial epigenetics, genes, adiposity, on this whole concept of DBCD, or the dysglycemia-based chronic disease. So obviously there is a link between visceral adiposity and atherosclerosis. That's very well documented. And we have a lot of inflammatory adipokines, which some of them are anti-inflammatory, some of them are pro-inflammatory. And they keep on changing. We have omentin, apelin, adiponectin in the protective space. And in the pro-inflammatory space, we have isfatin, ABFBP, resistin, and so on and so forth. And this list keeps on increasing all the time. And have agents really made a difference, anti-diabetic agents, on glucose and adiposity control? We don't know, but the data clearly shows that most of the glucose-lowering studies showed mixed results on macrovascular outcomes. And that's partly true because of metabolic memory, and that's probably speculative when I talk about it, but there's some data on suggesting that. And then, of course, came the new blocks on the kid, the SGLT2 inhibitors. They lower A1C with a little impact on lipid profile, and they still work. So that's something, but I'm certain in the last 3 days has been discussed a lot by everybody. We also have to consider, when we are looking at this whole conundrum of triglycerides as a residual risk, the role of statins. Because whenever there's a residual risk, that residual risk is defined onboarded patients with statin. So do statins really have a role on or control on adiposity? Let's look at the look ahead trial. And we clearly have seen in that intensive lifestyle intervention focused on weight loss did not improve cardiovascular risk in type 2 diabetes in long term. So that data is clear cut. If you look at the AVCSD risk as by the calculator, clearly we see that data is negative. It's not very, very compelling and positive. But the slides shown by the industry is predominantly the LDL lowering effect on benefit of statins. And these are all the primary and secondary trials. And in that space, if you look at it, despite of statinization of the world, we still see that residual risk. And clearly we see that on statin trials, on 10-year risk on major CVD endpoints, on primary prevention, we see around 8 to 35% relative risk reduction. This is a summary of HPS diabetes, CARDS, ASPEN-1 prime, and ASCOT diabetes. And when you look at secondary prevention, it's around 13 to 50% relative risk reduction, whether it's 4S diabetes, HPS diabetes, ASPEN, KR diabetes, TNT diabetes. So that's the summary, that despite of all this, there will be a residual risk which will be left over after statinization. So when you look at statin therapy also, there is a new term which was introduced almost a decade back in the United States called intensive lipid lowering therapy. And as we talk today, next week, the Lipid Association of India is in Delhi, when RS is there celebrating its 50 years. And they are also debating this, that is there still a residual risk? The first trial which put simvastatin in the NICE guidelines in UK, in NHS, was the Forest trial. That's almost 20 years old now. Then came CARE, then came lipid, then came HPS, then came TNT. But there is still, after a decade of statinization, in diabetes, after intensive lipid lowering, a degree of residual risk. And that residual risk is there. So here's the data. And we have now divided our lipid therapies, of lipid lowering therapies, in different groups. High intensity statin monotherapy, moderate intensity statin monotherapy. Then of course we have the ezetimibe. Then of course the PCSK9s have come in. And of course we have the low intensity statins. And even if you achieve 2016 goal, 19 goal with established atherosclerotic cardiovascular disease, you will still see a residual risk. And you can see the data here on the slide, anywhere ranging from 8% to 67%. So it's a very big clutter there. What is responsible for it? Is it the triglyceride? Is it the LDL cholesterol? Is it the remnant cholesterol which is driving that atherosclerotic vascular risk? And that data is now available. It's emerged in 2020. And this is a very nice editorial comment I would ask all of you all to read, that what is remnant cholesterol? It's nothing but total cholesterol minus HDL cholesterol minus LDL cholesterol. And it really corresponds to a risk which remains. So if you look at remnant cholesterol, lipoprotein little a, for which we understand precious little about, and ApoB, all the three are determinants of atherosclerotic cardiovascular risk. And a 30 milligram per deciliter increase on non-HDL resulted in 19% increase in cardiovascular mortality, compared to 15% on LDL cholesterol. So that data has also emerged very clearly. And if you look at remnant cholesterol levels more than 30, they were clearly able to identify or stratify those individuals with high risk of MACE events, independent of LDL cholesterol. So that's really the overarching philosophy, that you have that so-called non-HDL cholesterol emerging as a AV-CSD risk, clearly there. And this is that big data which Raman Puri, who's the head and founder of, who's a cardiologist from US who migrated back to India, put out on the Lipid Association of India, the meta-analysis of more than 62,154 patients statin treated on 8 trials, 4S, ASCAPS, lipids, CARS, TNT, IDEAL, SPARC, Jupiter, revealed that one standard deviation increase in LDL cholesterol, ApoB or non-HDL cholesterol, increased the cardiovascular event risk by 13, 14 and 16% respectively. So that's something which is very, very compelling. And if you look at, and when you put this through the filter of multivariate analysis of risk for all-cause mortality and myocardial infarction on statin-treated patients, and the best data is available from Scandinavia, from the Copenhagen General Population Study, clearly you can see the discordant values. See the discordance here in this. And this clearly reflects the residual risks. And you can see that residual risk exists despite of statinization. So if you see that risk is driven predominantly by non-HDL ApoB, and that's something we need to recognize, and there is still a risk of myocardial infarction and all-cause mortality. So that's something very, very clear. So ApoB got into the spotlight. So if you have to identify somebody with residual risk, either it's ApoB or non-HDL cholesterol. Is it just a triglyceride? We don't know. I will come back to it a little later. That's why I said, with Nita's permission, I wanted to deep dive what's happening today in 2020, 2021, 2022. And if you see that residual risk profile, in the discordant analysis, it clearly shows ApoB is the most accurate marker. And the threshold for ApoB as a risk modifier in statin-treated patients particularly should be closer to 92 than 130. That's the overarching thing. So keep your LDL as close as possible. So eventually it all came to risk stratification, and everybody got their own calculator. In India, we still need to generate Indian science to generate its Indian calculator, but it's all about this. It's all about predicting atherosclerotic cardiovascular risk. So if you want to predict incident atherosclerotic cardiovascular risk in Indians with traditional risk models, based on Western population risk profile data, it is a challenge. Because we all know that Framingham risk score predicts and overestimates in Asian population who have a lower incidence of coronary artery disease. And it also shows a disproportionately high incidence of stroke. So this is very clear that in the Indian population, if you apply the Framingham risk, you will over-magnify stroke, under-magnify coronary artery disease. That data is now available. Also, if you apply the 2013 ACC-AHA pooled cohort, clearly we see that the incidence of cardiovascular disease in Asian Americans, that data is available right from friends like Alka Kanayaga's group, the Masala study, and various others, including NASA and us, who are all migrant Indians, second generation living in the United States. Clearly what we have seen from that data, and this was compiled, of course, by Durai Raj, that in South Asians, the coronary artery disease is more extensive, more intense, and more adverse in outcomes. We have some retrospective data to show that JBS3 is performed best in people with multiple risk factors. So we all know this risk calculator came out in 2019 from the American College of Cardiology and American Heart Association. Clearly you know that you can look at each age group below 19, 20 to 40, 40 to 75, and above 75. And clearly triage people in high risk, intermediate risk, borderline risk, and low risk. And I don't want to go into the ABCD risk enhancers in this population because we all know this. People with family history of premature atherosclerotic vascular disease, persistent elevation on LDL, chronic kidney disease, metabolic syndrome, which is very prevalent in our country, and our own South Asian ancestry, obviously becomes the risk enhancer. So clearly, from that standpoint, it's clear cut. So if you look at models, including the Framingham model, on diabetes and incident diabetes in adults, clearly we can actually give points now. And Wilson et al. Put out this paper quite some time back, almost 14 years back, on fasting glucose gets 10 points. BMI 25 to 29 gets 2 points. BMI above 30 gets 5 points. HDL below, men and women have a difference at 5 points. Parental history of diabetes get 3 points. Triglycerides above 150 came 3 points. That's where triglyceride comes now. So I'm sorry I've started my triglyceride story a little late. But triglyceride is nothing but an epiphenomenon of triglyceride-rich lipoproteins, and it's all linked to our carb intake. And of course, hypertension comes up right up there. And then of course, as I said, Kerala data from Pauline Paul has very clearly shown on the JBS3, which was published in 2020, that if you look at lifetime cardiovascular risk score on a large pool of population or intermediate 10-year risk score in our population, there's a risk continuum. In Indians, there is a risk continuum. We see this risk continuum. And therefore, if you compare all the risk scores, whether you take UKPDS, Framingham risk score, atherosclerotic cardiovascular risk engine, the JBS3 score, age is there, gender is there, BMI is only there in the Indian component, ethnicity we don't know, we don't have adequate data. And then whether triglycerides come there, anything else comes there, we don't know. So there are a lot of ifs and buts in these scoring patterns. And obviously the endpoints which are studied also. The high-risk cutoff changes. UKPDS was more than 10%, Framingham was more than 20%, atherosclerotic cardiovascular risk engine was more than 10%, JBS3 was more than 20%. And cardiovascular death, non-fatal MI, angina, revascularization, fatal non-fatal stroke, TIA, intermittent coronary and heart failure. Now our SGLT trials only focused on predominantly the heart failure as an elephant in the room with some non-fatal MI and angina, and then they moved out. If you look at the old proactive trial, and we have Dr. Panikar here, if you look at pioglitazone data, they had data even on the stroke, which was removed. So, the cardiovascular endpoints kept on changing, and so did the scores. And therefore, when we look at recommendations for risk stratification, probably the JBS3 risk calculator to estimate 10-year risk for residual risk still is pretty certain. Total cholesterol and non-HDL from a non-fasting sample can be used. non-HDL instead of LDL may be a little more compelling. And people who are at residual risk are people who are diabetic above 40, probably with CKD and family history, and our own Asian ancestry, clearly there. So obviously we need to reduce that risk reduction, and that data is available. We have the ADAPT data to show with cluster analysis that we need tight glucose control. So we need to connect the dots. We clearly need to connect the dots of vascular complications with insulin resistance due to adiposity that drive the metabolic complications of cardiovascular risk. We clearly know insulin resistance has endothelial dysfunction, a lot of excess sympathetic nervous system activity. I saw Neeta was rushing here because this program had run before time. So it's all our sympathetic response, glomerular hypertension, renin-angiotensin activation, leading to micro and macrovascular complications. Clearly, here comes triglycerides. Triglycerides and remnant cholesterol, and not LDL or not HDL cholesterols, are associated with a MACE outcome, which is adverse. And its first inclination came from observational analysis. And I'm sure you all know the Predimed prevention diet trial. It came from lifestyle. And we clearly know remnant cholesterol carried VLDL, IDL, contributed by atherosclerotic risk from the Copenhagen General Population Study participants. We also know that currently in the real world, achieving a non-fasting, non-HDL target along with LDL is a feasible strategy to mitigate risk in our population. That's a feasible strategy. And that's why the Lipid Association of India recommends do a non-HDL. It's a much more accurate predictor, particularly in people with diabetes who have high triglycerides. So that's where triglyceride comes in the focus, and that's why probably Neeta and Sanjay wanted me to discuss this topic. In diabetic people, obese persons who are already on a statin, because they have that residual risk. And that's the importance. And now she's starting a cardiac hospital, I'm told, in Belgaum. So obviously she needs to recognize residual risk, because that's where the reversal can start of atherosclerotic disease. Non-HDL is as important as LDL for lipid-lowering therapy. And monitoring of non-HDL does not require a fasting sample and takes care of both the LDL and triglyceride targets. And in all individuals, non-HDL should be kept below 30. So that's also clearly there. We know that ATP3, Scott Grundy's data from NCP showed, and they recommended use of non-HDL for achieving LDL and triglycerides if triglycerides are more than 200. In our population, triglycerides are always about 200. And that's why JBS3 recommends on the consensus, which was the Indian consensus which Raman Puri led as a group, clearly showed that non-HDL should be the preference to LDL in the lipid-lowering therapy. And we had done our own with Dr. Mohan, ICMR and DAB. I was in charge of the lipid cohort that time. And NICE recommended non-HDL by 40% on lipid-lowering drug for secondary prevention. So did the US, so did the International Atherosclerotic Society. So clearly serum triglycerides are right up there. They are the first biomarker which we recognize to see that, because we don't do non-HDL all the time. And they do serve as a residual risk factor in atherosclerotic disease patients with optimal medical therapy. And therefore, strictly maintaining your triglyceride levels is necessary for optimal management of coronary artery disease. So obviously, that's what she told me to talk on, and that's where the data is. So circulating triglycerides are the current focus on residual risk. And this is the FMD-J study A data, clearly recognizing that if you have low normal triglyceride below 100, high normal 100 to 149, borderline 150 to 199, moderate hypertriglyceridemia. And they looked at outcomes between triglycerides and first CV events, first onset, death from CV disease, non-fatal acute coronary syndrome, non-fatal stroke, and coronary artery disease, and followed them up for 3 years. And the Kaplan-Meier was clear-cut. Okay, clearly it showed that serum triglyceride above 100 was associated with increased risk of first major CV events compared to people who were below 100. So that data is clear-cut beyond reasonable doubt. So I don't think we should have in our thinking that triglycerides are not important. They are important, and they can predict, and 100 is the key number. It's not 150, it's not 200. So in clinical practice, strict attention should be there both on lowering serum triglycerides as much as LDL to really prevent atherosclerotic residual risk in coronary artery disease patients. And this is the data which was published in April 2019 in Circulation, showing triglycerides as a residual risk in atherosclerotic cardiovascular disease. And this is how the first major cardiovascular events, because it's all about outcomes. That's how the Kaplan-Meiers separate out very clearly. And this is a more cluttered slide, This slide is just not meant to check your eyesight, but it only shows you that whether it's non-fatal coronary artery syndrome or stroke or coronary artery disease or hospitalization of heart failure or death from all causes, there is a link with triglycerides. Don't ignore it. Don't get carried. I know we have a Westerner in our audience as our ADA president. Don't get carried away by that because our data might be a little different. And we need to recognize triglycerides still. And now the world, cardiology world, at least in the US, is recognizing that. They're recognizing that for various hazards ratios, when you adjust it, there is a link between triglycerides and first major cardiovascular outcome. So that data is clear-cut. So initially they were skeptical. Now that data is coming there. It's coming up on the guidelines as well. And if you look at American Heart's journal, original triglyceride research in the KP REACH study, better data came out in October 2021. And clearly, Go's group showed, Alan Go's group very clearly showed that triglyceride levels have a linkage and remain the highest residual risk markers, probably as a causal role on cardiovascular events. Whether it's deaths, all-cause hospitalizations, major cardiovascular events, so on and so forth. And that data is pretty compelling. That cohort which they recognized, which was published, had a clear-cut hazard ratio. And despite of receiving statin therapies, elevated TG levels were associated with more atherosclerotic cardiovascular events and lower risk of death. Clearly that data is available. Again, a cluttered slide, I don't want to get there. So obviously what it taught us, triglyceride levels decreased with age, were lower in non-Hispanic Africans, higher in Hispanics as well as Asian and Pacific Islanders compared to non-Hispanic white patients. So that data is clear-cut now. That's something which we recognize from that study, at least for the US population. And clearly it also recognizes that elevated TGs increase major adverse cardiovascular events, decrease risk of death, and the established cardiovascular disease. So clinically, triglycerides function as a surrogate for atherosclerotic cardiovascular risk, as well as a biomarker for nutritional or carb status. And therefore, if you want that additional risk reduction strategy, and you further want to improve that residual risk reduction outcome, you need to look at it and not ignore it. And that data keeps coming up. From Brigham, Frank Sachs and his group also published this data, again recognizing the same thing in American Journal of Cardiology. Again, very clear-cut data, control study, high TGs have a role. So obviously there is evidence to suggest that higher triglycerides are a marker of cardiovascular risk and may help you to identify people who might benefit from intensification. But we still don't know much about genomics of triglyceride-rich lipoproteins and cardiovascular disease. That's an area of research. So probably what we have learned today, and I know this is the last talk and I'm between lunch and all of us, is that there is a role for raised triglycerides and remnant cholesterol. And it's linked to intimal low-grade inflammation and atherosclerosis development. And that's what this illustration tells us. And clearly triglycerides and remnant cholesterol act through triglyceride hydrolysis and cholesterol accumulation in the arterial wall foam cells. And that's what leads to atherosclerosis. And there's enough epidemiological evidence to suggest that they are markers of risk. There's additional information now available that despite of statin therapy, they are a residual risk marker. There is enough data now to suggest that they have independent association for future cardiovascular events, though this is a little controversial in the US world. And now there is emerging evidence from the genomic standpoint, epigenomic standpoint, where probably we'll understand better on serum triglycerides and causal pathways. So that's something which we'll recognize in times to come. So as I said, we need to connect the dots, and that's where adiposity, metabolic complications, vascular health, carbs which we eat in our foods, triglycerides, all get linked. So don't miss out on the remnant cholesterol and triglyceride because they have an impact on the MACE outcomes, and therefore they are a residual risk factor. Triglyceride levels are a residual risk factor, and that's the only point which probably Neeta and Sanjay wanted me to tag, and their entire group. Congratulations for this wonderful show. This is a fantastic auditorium and a fantastic venue. I really enjoyed it. Okay, thank you so much.
Shashank, that was crisp, You deviated from the target but came back there. Any questions from the audience?
I'll be the last.
Yeah.
We are friends now. At least, yeah, because the environment is good.
I like that.
Shashank, a question for you. Let me ask you from the clinician's perspective that we keep getting, if you have to look at from a hierarchical order for cardiovascular risk, where would you put LDL, non-HDL, ApoB, ApoA ratio, and LPLA in terms of, if I have to stratify cardiovascular risk for my patient?
So let me start from the reverse order. LP little a, evidence-based unknown and emerging, okay? In Indian population, it has a role, but we don't have outcome data on it. So little a is clearly there, but we don't know much, and I cannot say it as a recommendation. Nobody recommends it. So that's the first thing. As far as the other three which you talked about, ApoB, HDL, LDL, and triglycerides, they're all there. So they have to be all seen in continuum. And we have to sort of look at phenotype or a lipid phenotype of each individual. So that's a composite which we need to see. If you see Professor Enas and Enas, he actually got a score with lipoprotein little a incorporated in it. When he did a study called CARDI 22 years back, which is the coronary artery disease among Indians, which he published in JAC. But the data on that, which is outcome data, is very poor. So we have to look at hierarchical evidence. So in the hierarchy of evidence, non-HDL cholesterol is right up on the pecking order with ApoB. They are right up there. Followed by LDL, followed by probably, triglycerides. But the lipoprotein little a, I would put a question mark. I don't think it's prime time still to put it on the recommendations. By 2023, we will have 3 outcome trials. And 1 outcome trial which will be now presented at the American Heart in October, and 2 more next year, where we'll have better data on the little a standpoint. But that's where it stands. But maybe Gurumo is with us. He might give us some better insights with us. Yeah.
So that was a beautiful lecture, and I'm almost convinced, but at the same time, a little confused. So if I look at the American Diabetes Association guidelines, says treat LDL cholesterol and kind of ignore triglycerides and ignore non-HDL cholesterol. And I'm wondering, looking at your data, is no question for renal or secondary prevention is very important. But what about for primary prevention? And what is the discordance that I have? I'm confused now in the way that the ADA would say just bring the LDL down and ignore non-HDL only when it's above 500 triglycerides, do something. Can you clarify that? My mind is maybe the time frame and time different. I'm very confused. What should I do with my patients?
So I'm as confused as you are. But let me be very transparent here, without any bones minced on it. I think ADA stuck to that statinization philosophy, but they downgraded it to 40 and 75 as the most high risk. And that's where they stuck at it. But unfortunately, we see in the diabetic milieu, which is a metabolic milieu, the residual risk is very high. And the marker of that is triglyceride driven by the carb diet. And that's what PredMed showed us, that if you actually restrict carbs, actually the impact is clear-cut. So caloric restriction and carb restriction is the key on triglyceride control. Now, traditionally, your good friend Scott Grundy, he never believed in triglycerides. He was so obsessed with this whole concept. And late Jerry Riven, and may, God bless his soul, they used to sort of make fun of him when he described insulin resistance. And the aggressive US cardiologists will never allow that space. Now they are allowing the space, but I think the diabetes world is still stuck to the old cardiac paradigm. So I think in the ethnic groups of Hispanics, Asians, Islanders, Pacifics, which are high risk, probably they need to relook at beyond statin strategy as far as the IDEA guidance is concerned. And there is evidence base to support that, including outcome data. So I think there they need to make a change, and I think they are still in that little slumber which needs some modulation. And maybe in the 2023 revision, they will look at that data because, every 3-4 years they look at it. You are now on the board, you know that how it happens. But probably that needs to be done, at least in the high-risk category groups of the ethnic specific groups. Because what has happened is predominantly the window in the US is only the Caucasian window and all the outcomes in the Caucasian window. And therefore they only looked at it from that standpoint and they didn't look at it from the other standpoints. But now we are in a multi-ethnic world in a single global village. So obviously we need to look at it from that standpoint. So that's the confusion. I hope I can answer a little clarity on what you are talking about. But I think AD got fixated on the statinization. The American Heart ACC is now moving a little better on it. And they're allowing allowances for ethnic groups, for BMIs, and are recognizing non-HDL much better than what they did probably 5 years back. Because the data in 2019 to 2022 has been pretty compelling. And the level of evidence is now growing up from B to A probably.
Yeah, the ADA is working very close with AHH and ACC. I have one more question. So for many, many years, we learned that low HDL is a tremendous epidemiological predictor of cardiovascular disease. Raising HDL didn't pay off in reducing cardiovascular disease. So taking that as a consideration, and now non-HDL, perfect, is a strong marker and predictor, but does reducing non-HDL improve cardiovascular outcome in contrast to raising HDL didn't pay off?
So nobody knows the answer why the HDL story failed or upping of HDL story failed. And we don't know whether it was pharmaceutically driven or not, but probably not. But the upping of HDL, every trial failed. And I think what happened is that the statin lobby was a very powerful lobby. So, this is offline, but I recognize that HDL is all related to exercise. Triglyceride is all related to the carbs. And the LDL cholesterol is all lead to plaque stability or the vulnerable plaque which gets disrupted. What statins did probably is prevented sudden deaths by plaque stabilization beyond just lipid levels. And that data is clear cut on the inflammatory standpoint. But as far as the HDL goes, you can increase HDL just by exercise or by insulin. The point is, HDL, like lipoprotein(a), we don't know much about it. And if you look at its different subtypes of variants of HDL, I don't think, Gurmo, we have the last word on it. And I still don't know whether PCSK9 will have answers on the HDL standpoint. There are some very compelling data which will come out maybe another 3-4 years from now, which might give us that answer on the HDL upping standpoint. So the last word on that is still not out, if you ask me. And nobody puts money into a lifestyle trial now, except the NIH. So we must recognize NIH that they did two very elegant studies, both DPP and look ahead. And both these gave us some good outcomes.
And may I ask one more question?
Sure.
I mean, I think you are so knowledgeable. The Accord triglyceride trial, so reducing triglyceride in the Accord trial, 10,000 patients, that, didn't improve outcome, except for the very high triglyceride levels. So would that explain why the ADA and the Americans are not moving forward to reducing triglycerides in patients with diabetes? I'm just wondering.
So you know that Accord had its own challenges. It was done little too late in the population and the natural history of the disease. So Accord was too fast, too quickly, and done too late. That's all of us know that. So that's probably the reason we didn't get that. So unless until the trigs were very high, we never saw that. Because the persons who had looked at Accords were predominantly, the source of patient pool was very late, maybe after a decade and a half or 2 decades. So that's why we didn't pick it up. It has to be done early. Probably. That's probably the answer, as I said again.
Translating your beautiful data into a handsome, like your dress, in a prescription, insulin and triglycerides. Your friends want OHA, you used to promote insulin. So do you agree that early insulinization may protect our carb-eating Indians, unlike the fat-eating, okay? Number 2 is that lipid estimation in our laboratory. Whom do you trust? I don't know what, the Belgaum, see, they indirect estimation, direct estimation, unless otherwise we improve or strengthen our laboratory. All these talks, one has tried it, gadgets. And finally, it is the free fatty acid. That is the seeds of our insulin resistance. So triglycerides is the culprit. We agree with you. How do we fight it out? we will join together, whether it's OHA or insulin. Maybe diet, India needs as a change.
Thank you. Thank you. Thank you so much. I value your comments. Yeah. So I had actually slides on that, but I hid them. And actually they did come up on this presentation because that was my final version. I think I downloaded in the hurry the other one.
Yeah.
So there are two slides.
My question to you is that we are not really, especially for our diabetic patients, we are not routinely, which we should be doing, we are not routinely checking the cardiovascular risk score.
AVS-CD score.
AVS, yeah. And if they have had an event, they're already on statins. But I'm talking about primary prevention. Framingham is really no good for diabetic patients, first of all, and second, the ethnicity. But the only two scores are both British scores, the JBL as well as the QRISK 3. However, both these scores take into account the Indian ethnicity. And now there are certain studies from India.
Migrant Asian Indian ancestry from United Kingdom of Birmingham and Leicester, which is Gujarati and Punjabi. So let me be very specific about that also.
Agreed.
I'm sorry,
but that's all we have now at the point, at this
that's fair.
point,
That's
which is
a fair
something
point.
close to where
Nita, I
we are.
100% agree with you.
Yeah.
Yeah.
So, should we be actually doing some studies on comparing these two scores in our patients, like
Absolutely.
outcome prospective studies, and then use those scores? Because developing new scores, I think, is a huge task. So, if already the JBL3 and QRISK can be compared and actually look for the outcomes, what do you think about using
So
these
Kerala
scores?
has used the JBS3.
Yes, yes.
But there is data from Dr. Prabhakaran's group, which is Srinath Reddy's group. They have used QRISK. And we have data from Dr. Shamanna from Bangalore, who is using that twin. They have used QRISK also in that. So QRISK is being used by some people, but it has its own challenges and limitations. And QRISK is again more used in the peri-bariatric remission space.
Okay.
Okay. So again, that's the conundrum there, that this population which is coming in is a little higher on the BMI threshold, and that's where they're using it. If you go to a US cardiologist in a US meeting, or I sit across with my friend from Atlanta, they are very fixated on AVCSD because they feel it is reproducible and consistent. While QRISK, its reproducibility and consistency is being debated. It's not established as a standard of care. And also remember, Americans will never accept any other score apart from their score in their guideline. But QRISK is a very good tool in the Indian population. I have a QRISK calculator on my phone.
Yes, so do I. We are doing it
and
for
we
our
use
patients.
it
Yes,
to risk stratify, but we don't use it in general practice.
Right.
We use it in research tools and trials. So Dr. Ishita, who works with Dr. Panikar and me, she uses it for stratifying patients for a program. But we are not using it as a standard of care. We need to validate it. I completely agree with you that we need to validate it. We need to make it more simpler, as my good friend Dr. Karunanidhi said, that we need to make it more applicable for our population. We are not doing that, and we also need to do some more Indian science on this. Yeah.
I don't know if the chair will allow me one more question.
This is the last talk, so we can go ahead.
The American College of Endocrinology guidelines coming next month, and they now, I'm part of that, but now the lipid people added a extremely high risk. So we have high risk, bring the LDL down, and then now it created something like extreme high risk. And they want the LDL cholesterol to be less than 55, although they pay attention to triglyceride more than the ADA. Do you agree with this extreme name, bringing the LDL less than 55 in patients at high risk of heart disease or with established heart disease?
So let me be very transparent. You and me have been a part of ACE for the last 25 years, both of us. And you have been on the board also. And I've been very active for the Indian chapter, which I've left some time back to Dr. Rakesh. Clearly, we know two things. On the science standpoint, all ACE guidelines were one step ahead of the ADA guidelines. Only problem was the therapy space they conquered, and they got that nickname that they were too pharmaceutically oriented. So that's the only challenge. But I think the very high risk group is very pertinent to Asian Indians, to Pacific Islanders, to Hispanics. So identifying very high risk is, I think, a reasonable step. And I think ADA should also adopt it. So I think that's where the big societies all should collaborate. Ideally, there should be a joint guideline of ACE, ADA, and endocrine society, or at least of ACE and ADA. That's not happening that frequently, and but very high risk group, I think, needs merit, and there is merit in it. And I think keeping the LDL low without not mentioning triglyceride is a reasonable point. So I think the science which they have done is correct, but whether it should be treated and whether that treatment has an outcome is still speculative. That's where I would put it. I hope that answers your question.
Thank you. I think I'm feeling hungry now. Okay.
I have one diabetic young lady, 34 years old, who had bad coronaries and underwent bypass surgery. And now she wants to have issue, but she's on statins, which are sort of absolutely contraindicated during pregnancy. So we are in a fix. And there may be other patients who had gone on angioplasty or IHP who are on statins.
So this is a common thing which we get. Formerly it was much easier when the Indian law was little easier. And Sanjay's wife would have been happy to be here, because she and me also meet quite often on the gynec societies and in the infertility space. And they would have easily done a surrogacy, and it would have been easy with artificial ART. Now law has changed, but that's the best option. For such individuals with a bypass surgery done at 33 with diabetes, I would still recommend there is a medical indication for surrogacy. And that's the first option. In absence of that, if you want to stop the statin and keep the LDL low, you have non-statin mechanisms to lower it. This is like people who are on glargine, which is not approved for pregnancy, who are type 1s get pregnant, but they still do very well. So it's not that they will do badly. Okay, you may still be able to allow to continue, but you can use non-statin options as well. The only problem is about plaque stabilization and plaque rupture. That's the only challenge, so you'll need more cardiovigilance. So there are doctors who switch off these patients on statins under cardiac supervision, and they are allowed to get them pregnant. So we have handled, Dr. Panikar and myself have handled such high-risk cases, but it's not an easy task. Formerly it was much easier. We should just call up Nandita and Rishikesh, who work with us at Lilavati, and we should just tell them that, look, take over and just do surrogacy and close it out, because it's not worth that lady going to the risk of pregnancy, threatening her life. Because maternal life-threatening risk is supreme. That's something which is very clear. Also, the evidence based on statin is complete. So we need to also see what is the LDL value, what is the HDL value, what is the degree of dietary manipulation. We have omega-3s which can be allowed in pregnancy. We have a lot of other alternative options, including an ester eicosapentaen oil, which doesn't have data in pregnancy, but presumably might be safer. And I didn't again touch on that, because that was in that other slide of mine, which the deck actually, I put out a deck 1 and I should have put out a deck 2, but that ester also I didn't touch about. Very good data. Deepak Bhatt, who's an Indian scientist at Harvard, has published that data. Excellent data on that. Omega-3 derivative. So we have a lot of good options now. Formerly we didn't have those options. Now we have options, safer options, and we can look at that.
So I know this is the last lecture. So if you have a point, you want to raise this point to the American Diabetes Association standard of care. So we meet every 2 weeks. And if you submit, if your name is very well known everywhere in America, so it will be well received. If you have a point to raise about non-HDL in patients with diabetes, if you submit a letter requesting, it has to be addressed for sure by the Professional Practice Recommendation Committee, but it has to be before August 30th. And they have the obligation to respond to you with your concerns about just focusing on LDL. And maybe you can raise the point to be addressed. Maybe we're already August, but this year or next year. But this is the way that the Professional Practice Recommendation Committee listen from the expert. And maybe it's the way to move the needle forward.
I'll write it up. I'll write a letter. Thank you.
Yeah, I recently spoke on lipids and pregnancy in Dr. Benny's conference, virtual one last year. And there I reviewed what he is actually asking, that statins are out. So either you have pregnancy or you don't have pregnancy.
You have surrogacy. I gave the
Ha.
option.
But you very rightly said non-statin drugs, especially omega-3 fatty acids, diet, lifestyle modification. In fact, diet management goes a long way in preventing those complications. And about 10 or 12 patients in 22, they have reviewed where they have done for very high levels of LDL. Apheresis has been done and results have been very, very encouraging. But it will be only non-statin drugs and omega-3 fatty acids and other diet modifications.
But LDL apheresis is a little too far-fetched.
It is too far. I know.
Thank you.
They had
Give
only
Shashank a
11
big hand here.
patients. Yeah. Him to bind all the delegates around. Shashank and finish.
For the delegates, I know that lunch hall is in the way, but if you can just step 4 steps ahead and come to the other hall, where we will have all our concluding remarks from Dr. Sanjay Agarwal and Professor Umpiras of the entire conference. So we request you to just come there for 5 minutes to the hall A. And then we can have lunch.